I think one of the other things that I normally do is instead of doing a single incision, a single stitch, I will actually do a few to make sure that the anchoring effect is really, really strong. So far, I have started this technique since March last year. I have had probably one patient with, which did not hold. I've done almost 400 over cases, 400 over lids now. So it's less than 1% that the crease disappears. So it's actually very, very, very good.
Mm-hmm. Wow. What type of suture that you use for the eyelid crease fixations?
I use nylon 7/0, or you can even use nylon 8/0 if you want it to be even finer.
Mm-hmm. And if there are asymmetrical eyelid crease height, how you repair it? By the mini incisions, or you do open blepharoplasty?
Well, asymmetry, I think it depends, right? If the primary surgery is in a full incision and the crease is like a static crease, then I think we need to go in using a full incision to revise the crease. But if it's just using suture, I can actually use the mini incision to correct the asymmetric crease.
Alice, what is the biggest challenge that you've encountered in Asian blepharoplasty? The biggest challenge?
The biggest challenge, well, I think, you know, to consistently create exactly same crease, I think it's just one of the toughest things. You know, I always make sure that I sit with a patient, you know, during the counseling session to tell them as much as we try our best to maintain a symmetrical dynamic crease, but sometimes it's just too difficult. So, you know, so we actually do allow patient and also offer patient, you know, some touch up, you know, after the procedure. So then I actually give them a 6 months period, sort of like grace period. If, you know, in case, you know, the crease doesn't form the way we want it, I will actually give them a free revision.
Okay, thank you, Alice, for all those insights. I would like to call now our next speaker, who is the Chief of Orbital and Plastic Surgery Division, Wales Hospital. He's also the Associate Director of the Chinese University of Hong Kong Eye Center and Director of Eye Center of the Chinese University of Hong Kong Medical Center. I now give you Dr. Kelvin Chong for his presentation on personalized approach to ptosis correction. Kelvin.
Thank you, Professor Habate, and thank you very much, Junia and Professor Lee, for the invitation. I'd like to share my screen now. It's just a personal overview of how I would, sort of more a collection of what I've managed my ptosis patients. I try to make things simple for the audience, so I'll make it D and C's. There's no financial disclosure. So when I am asked to assess ptosis patients, I always think of these D's: degree of ptosis, and more importantly, the degree of levator functions. I'm going to show you examples how the frontalis overaction and the Heron's phenomenon will be relevant. Dermatochalasis obviously is a major thing when we were looking in patients who have or complained of ptosis. As an ophthalmologist, I think we are in a much better places or expertise compared to our non-ophthalmology colleagues in assessing patients who have dry eye. Drops and documentations are always important. Phenylephrine has been a consistent procedure that I use for nearly every patient, and obviously looking at patients' old pictures will be very, very informative. Well, this is obvious frontalis overactions, which I don't need to preach to the crowd. But again, levator functions is something that we often important in deciding type of the ptosis corrections. The patients on the left with congenital ptosis with good levator functions obviously have much more choices and much better prognosis compared to the one on the right side. I noticed the lid lag on down gaze, which is very typical for congenital ptosis. Another example of elderly patients who have similar degree of ptosis on the casual glance, but when you measure the levator functions, they have very different levator functions, and so the options and the complications and prognosis will differ substantially. Well, dermatochalasis is a major thing because many a time patients will mistake dermatochalasis as ptosis, as shown in here. I think patients with concomitant ptosis and dermatochalasis should be clearly documented and shared with the patients pre-op. I don't need to preach to the crowd again, talking about various diseases of ptosis, but again, pseudotosis is something that I'm going to share with some pictures. You can see how the frontalis overactions is often very, very important in localizing and finding out the mitotic eye, like the patients on the left. But interestingly, I'm going to share with you one of my experience on cross-localizing a frontalis overaction of the patients on the left. He is a bus driver who comes in thinking that he was told he has euthyroid eye disease with upper lip retraction on the right side, pardon me. But in fact, there is no other associated sign of thyroid eye disease, and he responds quite well to phenylephrine on his left eye. So I convinced this patient, instead of operating on his right upper eyelid for lower lip, upper lip lowering, we instead do a ptosis correction on his left eye. And you can see in the middle of the pictures how the frontalis nicely do its job intraoperatively. And so I think frontalis overaction is often a very useful localizing sign, but be careful of the false localizing nature of that. Well, again, to personalize ptosis correction, I think that person can not only be just the patients, but also the surgeon, myself. Well, I'm trying different approaches, and hopefully in the coming years, I may be able to try newer things like MMCR plus, which means MMCR with tusectomy and the frontalis flap type of operation. But today I'm going to focus mainly on posterior approach, levator reattachment, small incision anterior levator reattachment, and some adjunct, which I found very useful. Well, we've talked about the D's, and now comes to the C's. These were common but important considerations when we manage our ptosis patients. Whether you want to cut skin or not, this warrants really considerations, as nicely commented by Alice. Our patients are very meticulous about their crease and as well as contour, the canthus as well as the closure. Remember, we are ophthalmic plastic surgeon. We put the eye, the health of the eye first and foremost. So, well, these were typical examples of patients who respond beautifully with phenylephrine. She responds very well with a standard MMCR operation. And other patients with similar, very good response to phenylephrine. These were really the easy or standard cases which beginners should first started with. But when patients comes in, this is a middle-aged male with multiple crease. He doesn't want a single lid crease because he has multiple crease on both eyes. So the only options I left to correct his ptosis is to do an MMCR. So he has his ptosis corrected, but we do not touch on his multiple lid crease on the operated eye, because otherwise we'll have to operate on the other side, and he doesn't want that. Of course, patients with concomitant dermatochalasis and ptosis, they're better off operating at the same setting. You might argue that an anterior approach levator resection together with ptosis correction, together with upper lip blepharoplasty might serve the same. But of course, for colleagues who operate on MMCR often, you know, this is a quick procedure. And I think in the economy of time, this is a very relevant choices. Another example of patients with dermatochalasis and ptosis, concomitant upper lip blepharoplasty and MMCR works very well. And we have to also ensure that patient understand that they're healing. Many of our Asian patients, their skin doesn't heal really well in the early postoperative period. So how about the options? When patients with a no lid crease, a vague lid crease, a broken lid crease, a low lid crease, sometimes there are alternatives. And I think posterior levator reattachment, we call that PLR, and small incision anterior levator reattachment, I call that CLL. These two options are really quite useful in circumstances. In a patient like this, she doesn't want skin incision, and she doesn't respond completely with phenylephrine. And posterior levator reattachment with concomitant crease-forming sutures will serve her very well. And other challenging patients with congenital ptosis, more significant degree of ptosis, and very severe frontalis overaction. The challenge for her is she doesn't want a skin incision, and she has a vaguely crease on the fellow eye. And in order to match her fellow eye, what I started for her is to consider for her is to do a posterior levator reattachment with a vague crease formation, single stitch that was removed 1 week. And she was pretty happy with that. You must understand, patient may not want a very obvious single crease. Some patients may have vague crease, and we might want to cater that. On the other hand, small incision anterior levator reattachment sometimes serves quite well. For example, in this patient with relatively lowly crease, we use a very, very small incision and 3 skin stitches that was removed in the first week. And other patients with small incision anterior levator reattachment with a crease formation, again, 3 small stitches and that can be removed in the first week. And other patients, similarly, the degree of ptosis correction, the degree of overcorrection in lagophthalmos has to be judged based on patients as well as my own sort of nomogram, how much overcorrection would be necessary. And other patients who really comes in 2 weeks before her daughter's wedding, and you see how this degree of ptosis correction can be achieved with very small skin incision and very tiny skin wound. And other patients who again have small incision anterior levator reattachment, and notice the degree of lagophthalmos that I allow intraop and small degree of overcorrection that justify over time. Well, and other patients with small incision anterior levator reattachment, the contour and how you manage the canthus, I think we have to be personalized as well. Well, again, you see these patients before with a false localizing frontalis overaction. He was quite happy with the results that we operate on the correct eye with a very small incision that heals quite well. Well, of course, this is a very tricky patient. My corneal specialist sent me this patient with a corneal transplant who is the better seeing eye. So in that perspective, I think posterior ptosis is not my option. And I do not want to touch his upper eyelid, removing the dermatochalasis either. A small incision anterior levator reattachment gives me the exact amount of lagophthalmos and ptosis corrections that I can offer to these patients. But there are some tricky points. Heavy eyelids with redundant skin, I tried myself, it doesn't work. Even though patients want, you might cautious the patients to do an open approach. That might be a more efficient way. Patients with significant dermatochalasis, again, she's not happy with the results, but she's much happier, even though the skin's wound is small, she's much happier after both upper lid blepharoplasty that was done in the second stage. Finally, I think in the interest of time, I'll just show you some pictures of the intraoperative titration of the canthus and contour. Well, I think local anesthesia is still my preference. I will sit the patients up and even give them a mirror to look at the results intraoperatively. When patient is happy, I'll take a picture as documentation and I'll close the wound. Of course, for pediatric patients, this will be difficult because patients will be done under general anesthesia. Last but not the least, I'd like to show you quickly 2 procedures that I find useful in very tricky cases, tarsectomy and tarsal switch procedure. This is a patient with very severe congenital ptosis. He already have a frontalis sling done twice, and even I explore the sling, there's no effect on elevating the upper eyelid. So instead of giving him a third sling, I do a tarsectomy and levator reattachment procedure. Luckily, these patients tolerate the procedure quite well. There's not a lot of lagophthalmos on table. And I do an adjustable in terms of the lid height at day 3. Although there is some lid lag that is expected in this scenario, he is recovering quite well, doing quite well post-op. The last patient, this patient has double elevator palsy and 2 ptosis and 2 eye muscle surgery. And the issues is she already have low lid retraction, lid lag on down gaze, and very poor levator function, and lagophthalmos as well. So instead of putting more sling in, I do a modified tarsal switch procedure. I take out tarsus from the upper lid and put that into the lower eyelid and put the lower eyelid on stretch for a couple of weeks. And you can see that I will titrate the amount of MRD1 correction and put that into the MRD2 so that she has better closure, correction of the lower lid retraction, and this is how she looks afterwards. So with that, I'd like to conclude my talk, and thank you very much for your attention.
Thank you, Calvin, for a very nice lecture of yours. I have a question for you. Do you perform single stitch, MMCR?
Professor Habate, I don't quite understand what you mean by
single stitch, MMCR.
Well, for MMCR, typically do a serpentine stitches back and forth. I don't quite understand what you mean by single stitch. You mean the knot on one side or both sides?
No, on one side, just a single stitch, because you know, I've read some of the I don't do it, but you know, in literatures, yeah, they published the single stitch. I have no personal experience with that.
I don't have that experience either. I think probably that's a single stitch open approach of MMCR, that you open up the skin levator and you identify the molars muscle and do the molars muscle plication anteriorly using single stitch. I don't particularly find this method attractive, because if I want to go posterior, I just do the standard MMCR procedure. If I want to have more control in terms of the contour and the lid height, I'll try to do the standard levator procedure.
When do you perform frontalis sling in patients with myasthenia gravis? When do you perform?
There is at least two criteria. I'll have to see, because in myasthenia gravis, patients tend to have variability. I'll have to see that there is a control, usually medical, in terms of immunosuppressant or maybe oral steroid, that there is no variability in terms of that ptosis. Then I will consider doing surgery for them. In terms of surgery, I'll also use that personalized approach. Patients who are younger, who are more committed in putting in lubricants, I'll tend to be a little bit more aggressive. Otherwise, I'll tend to undercorrect them.
Thank you. Thank you.
Dr. Kelvin, in case of unilateral surgery and you perform MMCR with the eyelid crease fixations, how you adjust the eyelid crease?
Well, this is a tricky question too, because in patients who need unilateral surgery for MMCR, I tend to look at that preoperative response with phenylephrine and show that pictures to the patients, because the phenylephrine in these patients tend to give you the results if you just perform MMCR alone. So if the patient is happy with the crease, in terms of the crease height and contour, I'm happy just to do an MMCR and without touching the skin. But if I have to do the crease procedure together with MMCR, I have to be very, very cautious. I tend to also set it a little bit lower than the fellow eye.
I see. Thank you for your answer.
Thank
So we are moving to the next topic. The next topic will be given by our chair, Dr. Reynaldo Jawate. He is the founding president of our society, and he is also the chief of lacrimal, orbital, and oculofacial plastic surgery in University of Santo Tomas, Manila. Today, he will give us the topic of rejuvenations of the lid cheek interface, lower lid blepharoplasty with mid-face lift. Dr. Jawate?
Yeah, I think the admin will play my video. Admin, please. My name is Reynaldo Habate. I'm a professor of oculofacial, orbital, and lacrimal surgery at the University of Santo Tomas. And I'm going to be talking about rejuvenation of the lid cheek interface, lower lid blepharoplasty with mid facelift. I have no financial interest to disclose. Even though lower lid blepharoplasty is one of the most common aesthetic surgeries performed, it is still a challenging procedure for occulofacial plastic surgeons, as it can have many short and long-term complications which are unforgiving. As a rule of cosmetic procedure, in order to decide what we're trying to achieve, we need to take a look at the features of youth: convexity of the lid, smooth interface between lid and mid-face, lateral canthus higher than medial canthus, no rhytids, fully verted lashes, Lid should describe gentle S-curve and should rest 1 to 2 millimeter above limbus. Cosmetic rejuvenation of the lower eyelid midface complex has evolved as our understanding of three-dimensional midfacial aging and anatomy has become more sophisticated. Treating the lower eyelid and the midface as a single aesthetic unit leads to more effective and natural-appearing rejuvenation. Although patients desiring lower lid blepharoplasty typically describe their problem as bags in the lower eyelids, there are many anatomical imperfections that should be assessed. With aging, the youthful single convexity of the lower lid separates into a double convexity with a valley at the intersection of the lower lid and midface. Midface descent further drags this intersection inferiorly, leading to a vertically lengthened lower eyelid. What are the techniques to rejuvenate the lower eyelid? There are techniques to address the lower eyelid, not just surgery. There is a place for botulinum toxin treatment, pelobase skin tightening, and non-surgical eyelid lift. But what I'm going to focus in this lecture is surgery. Similar to many facial aesthetic procedures, the current methods used in lower lid blepharoplasty have evolved for many reasons, including the lack of satisfaction with previous methods, complications arising from traditional surgical approaches, a better understanding of the anatomy of the aging periorbita, and appreciation of the components of youth. The individual components vital to successful lower lid operations have all been described in these previous articles. I would like to thank my good friend, Mr. Naresh Joshi, an eminent eyelid surgeon from UK, from whom I have learned some of the caveats of the procedure. A common thread of all these techniques is that many are aimed at improving the aesthetic outcomes while attempting to prevent postoperative complications such as lower lid malposition, scleral show, dry eyes, and frank lower lid ectropion. The surgical efforts were basically a perceived solution to the antiquated notion of getting rid of excess soft tissue, skin, muscle, and fat, in addition to straightforward access to lower eyelid fat without regard for the concurrent senescence of the supporting structures. For example, in this patient who was referred to me for evaluation and treatment of left lateral ectropion after lower lid blepharoplasty done by a plastic surgeon, I did the lateral tarsal strip to shorten the left lower lid horizontally to reduce the vertical lower eyelid destruction. And this complication might have been avoided if a lower eyelid suspension and lateral canthal fixation or reinforcement were performed at the time of the initial surgery. Lower lid blepharoplasty results are improved when lower lid orbicularis oculi muscle is preserved with minimal fat removal, if at all. The main retaining structure, orbicularis retaining ligament, is selectively released. Lateral canthal support is established or strengthened, and minimal skin is removed. The technique of lower lid blepharoplasty with mini-mid facelift begins with injection of local anesthesia. 6-O-prolene traction suture is placed through the more central aspect of the lower lid through tarsus for upward traction. Transcutaneous subciliary skin incision is made around 2 millimeters below the lash line using an RF electrode in the cut mode. A skin flap is developed for 5 millimeters, after which a cut is made through this preseptal orbicularis, and this will spare the pretarsal orbicularis and leave it intact. And when you come to cut excess skin, it will only be skin only at the end of the procedure. I'm a great fan of radiofrequency electrode. It helps me to make incision and retain the anatomical planes. After a cut is made through the preseptal orbicularis, the section of the suborbicularis plane is developed to expose the inferior orbital rim at the arcus marginalis, followed by release of the orbital retaining ligament. With counterballotment of the globe over the corneal lens, the fat bulge is quite readily seen. I begin exposing the fat pads through small perforations in the septum, herniate fat out, clamp, and apply bipolar cautery. Septal holes are then closed, orbital septum is then redraped, and sutured to the orbital rim with 6-0 vicryl suture. Cautery is then applied to orbital septum to tighten it and shrink the fat, and a 5-0 double arm PDS is used to fixate the pretarsal orbicularis muscle to the inner aspect of the lateral orbital rim. Likewise, the preseptal orbicularis muscle is sutured to the posterior inner aspect of the lateral orbital rim to elevate the lower eyelid and mid-face. Excess skin is cut and the skin is closed in an interrupted fashion using a 6-0 Prolene suture. Here's the patient pre- and post-op picture 3 weeks after upper and lower lid blepharoplasty with mini-mid facelift. She wanted a youthful look, and doing upper and lower lid blepharoplasty with mini-mid facelift yielded a better result. There is softening of the upper nasolabial fold, smooth and shortening of the lower lid cheek interface, and effacement of the tear trough deformity. Cases. This 58-year-old female who presented with significant lower eyelid bags with complaints of looking tired, requesting periorbital rejuvenation. She also requested the return of the almond shape to her eyes that were very dramatic in her younger years. Examination showed also her associated lower eyelid tear trough and prominent nasolabial fold, and this is after upper and lower lid blepharoplasty with mini-mid facelift. Shortening of the lower lid cheek interface with softening of the upper nasolabial fold is now evident, and effacement of the tear trough deformity. This 50-year-old female presented with a desire for improvement of her upper eyelid heaviness and lower eyelid bags. After upper and lower lid blepharoplasty with mini-mid facelift, there is now a better harmony of the lid and mid-face areas and reduction in the disjunction. This 80-year-old female presented for periorbital rejuvenation after upper and lower lid blepharoplasty with mini-mid facelift. Cheek and lower lids appear more youthful and balanced without lid malposition or an over-operated appearance to the lid-cheek junction. This 82-year-old female presented with desire for improvement of her lower eyelid bags after lower lid blepharoplasty with mini-mid facelift. Her lid-cheek junction and malar fullness have improved. This 57-year-old female presented with a right large lower eyelid bags after lower lid blepharoplasty of the skin flap, orbicularis muscle, and lateral canthal fixation. The bags were gone, and there is shortening of the lower lid cheek interface. This is a 62-year-old male who complains of bags in the lower eyelid with tear trough deformity and mid-face descent. 2 weeks after lower lid blepharoplasty with mini-mid facelift, bags were gone and effacement of the nasojugal and palpebromalar groove. Another 60-year-old female presented with desire for periorbital rejuvenation after upper and lower lid blepharoplasty with mini-mid facelift. There is now absence of rhytids and shortening of the lid-cheek junction were noted. In general, as with any aesthetic surgical technique, modifications should be made for individual anatomy. Patients with substantial mid-facial volume loss may require mid-face soft tissue volume augmentation either by fat transfer and transposition, fat augmentation, or mid-face lift. Here is a result of a lady whom I did a mid-face lift with lower lid blepharoplasty. One could see the elevation of the malar fat pad and shortening of the lower lid cheek interface. Like the right lateral view shows enhanced cheek elevation. This is another lady whom I did also lower lid blepharoplasty and mid-face lift. One can see shortening of the lower lid cheek interface with softening of the nasolabial fold. The left lateral view shows enhanced cheek elevation and projection, basically imparting that apple cheek look. In summary, the lower lid blepharoplasty with mini-mid facelift is composed of simple individual technical maneuvers that when combined provide a powerful yet reproducible aesthetic eyelid shaping. It decreases scleral show and ectropion, the most common complications, allows direct fixation of tissues along the orbital rim periosteum respecting vertical vectors. So the lid cheek junction and are directly improved, and so with the upper nasolabial fold. All their perceptions regarding periorbital and facial rejuvenation focused on lifting, tightening, and excising. Aesthetic paradigm shifts now focus on selective treatment of known facial fat compartments, limited release of retaining structures, and techniques that restore or improve periorbital contour. Thank you for your attention.
Thank you, Dr. Jawate. I have one question. Do you ever encounter the problem of the pretarsal orbicularis oculi become larger when you do fixations, and the patients notice that the what we call dolly eye look larger than after the surgery?
Can you please repeat the question, because I have an unstable,
I see. Do you ever have the patients who you do when you do the pretarsal orbicularis oculi muscle fixations, when you do the lower blepharoplasty, and after that the patients had bigger dolly eye, the pretarsal muscle becomes swollen?
You mean chemosis? The conjunctiva? Yeah. Every time you suture the the periosteum in the lateral orbital rim, you usually expect some chemosis, and for that I just lubricate the patients, and they tend to disappear in due time. Yeah. Did I answer your question?
No, I mean from the outer side, the skin, pretarsal skin.
Yeah.
Swollen after the surgery.
The pretarsal skin.
Mm-hmm.
No, I don't have. Except, for example, for the meantime, patient will have some scar, but the scar tends to disappear. But swelling, no, I don't get it. I don't get it in my cases. Yeah.
Okay. So there's a question from the audience that do you also do the fat grafting or during your procedures?
Well, I do not most often than not, because I'm happy with my technique of this blending the lower lid cheek junction. But of course, like for example, I do extended lower lid blepharoplasty if the patient's request is limited to skin excess removed and soft tissue are still in their correct position. Meaning, if there is no soft tissue, much mid-face descent of the malar fat pad, then I just do this blending. I'm very happy with the technique, which was actually introduced by by Hamra, which is the septal reset, and of course minimal removal of those orbital fat prolapse, and then of course with the lateral cantopexy and orbicularis suspension. And I do get because with fat transposition, sometimes you get periocular hematoma, and then of course at times also fat pedicle hardening and inferior fornix granuloma. Those are the complications, I think. And of course, fat grafting. The drawback with fat grafting is longevity, and fat taking actually rate is quite low. So I'm happy with my technique now of this doing these combinations of the lateral cantopexy, orbicularis suspension, and then you try to incise the orbital retaining ligament, and then it gives me good results. Yeah, thank you for the questions.
Thank you. Dr. Jawate, would you introduce the next speaker?
Okay, our next speaker is the director of Shri Sankaradeva Netralaya, Guwahati, and head of the Department of Ophthalmic Plastic, Reconstructive Surgery, and Oculofacial Aesthetics, and past vice president of our society, the Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery, and also the past secretary of OPI, which is the Oculoplastics Association of India, Dr. Kasturi Bhattacharjee, on overcoming challenges of lower eyelid bags. Kasturi?
Can you see my slides, sir? Is it visible?
Yes, perfect.
Is it visible on slides? Okay.
Yeah, it is visible. Yeah.
Thank you, Professor Hawate, for the kind introduction. At the outset, I would like to thank Dr. Dongmi, Dr. Yunia, my very good friend, for having me in this prestigious forum of the facial aesthetics. So I'll be discussing overcoming the challenges in the management of the lower eyelid bags. I'm sorry, I do not have a good throat, but I do not have a good voice today. So no financial disclosure. So the common challenges in the management of the lower eyelid bags are basically when you need to conceal and contour the lower eyelids bag and also the tear trough, because this occurs due to multiple changes of the skin, the changes in the orbicularis, and we see the herniation of the back fat and also the resorption of the bone. So all this leads to multiple changes in the face as well, where we see the positive vector of the face changing into a negative vector. So when I discuss about the 5 challenges during the management of the lower lid blepharoplasty, one common challenge, especially in Indian scenario, we see is the prominent tear trough. The next being when you have a prominent tear trough along with prominent lid bags. The third being when you have a double convex deformity with a variable lid length. The fourth, when you have a double convex deformity with a lateral canthal laxity. And the fifth being a double convex deformity with the malar deflation and displacement, shown very beautifully by Professor Hawate. So the prominent tear trough that can be managed very well with injection dermal filler, where we inject into the tear trough area, which gives a very fuller, smoother appearance. But the only side effect is that, or the only negativity is that it's a temporary solution. But it definitely, if you look to the lady out here, it takes away the shadowing effect, especially in Indian scenario. You can see the pigmentation is much less and it gives a much smoother effect. But in situation number 2, where you have a prominent tear trough with the fat herniation, so what do? I usually see where the fat is. If the fat does not involve the lateral quadrant, and if the fat bag lies much behind the plane of the anterior lacrimal crest, so these are the situation where I go for injection dermal fillers. And this dermal filler can be given both by the needle technique or by the cannula, as mentioned by Dr. Bobby so beautifully in his previous talk. So I usually manage a mid-phase first, and this is being followed by injection of the dermal filler directly into the tear trough area. And you'll see that immediately after the injection, you can see the concealing of the lower lid fat and also the correction of the tear trough. Like this lady, you can see here, this is the corrected side and this is the uncorrected side. And you can see the beautiful concealing of this lower lid bag along with also the correction of the tear trough. So in the same way, now what I prefer is basically I use a cannula, but prior to the injection technique, you need to see whether it's only fat or fat along with the fluid. So once you mark the area that needs to be injected, and which is usually starting in the tear trough region along the inferior orbital rim, then I usually place a cannula, as Dr. Bobby has already mentioned. You open it with a 23 or 24 gauge needle, and then I use a 25 gauge cannula and inject it along the inferior orbital rim, where you can see like you need to cover the hole from medial to the lateral. And once it is done in both the side, you can see a very good concealing of the lower lid fat and also the correction of the tear trough. As you can see here, the same lady, just you can see this is the fat bag and with a prominent tear trough, and this is just 2 days after the injection. Similarly, in this gentleman, in another where you can see a very good concealing of the lower lid fat and also the correction of the tear trough before and after injection of the dermal filler. Not only this, the small procedure can also change the negative vector, which we can see here, to a positive vector following the injection of dermal filler along the inferior periorbital rim. And the results are very instantaneous. Like if you see, this is the injection site or the cannula, and this is just after the procedure, where you can see the whole of the lower lid bag and also the tear trough gets concealed following the procedure. So the third is, what do we do when we have a double convex deformity, which is characterized by the prominence or the herniation of the orbital fat, the lengthening of the lower lid. So in such situation, I always try to gauge the amount of the orbital fat prolapse that we have. And if this fat prolapse involves a lateral quadrant, and also when this plane is much interior to the plane of the anterior lacrimal crest, so this other situation, I go for the lower lid blepharoplasty. And I usually like to mention the beautiful applications of how much do we need to blepharoplasty and which technique. The paper by Dr. Feza et al., where he's mentioned if you have a short lid lengthening, you can go just for the fat removal. If you have a medium, then you go for fat removal along with filling up the trough. And if you have a long lid, then you need to go retripping or the tissue preserving technology. So here we can see this lady has a very short length, and also a simple blepharoplasty has been done where customized amount of the fat has been excised. And once the fat has been excised, you can see that she is very young, and a very beautiful effacement of the late cheek junction and also the correction of the fat bags. Another gentleman, as you can see, the simple technique of just a fat excision, and you can see the negative vector being converted into a positive vector following a simple fat excision, but a customized amount of the fat being excised. So another young lady where you can see a very good effacement of the lid cheek junction. But when you have a medium lid length and with the fat being prolapsed, you need to excise it. But a simple excision does not help you, as seen in the situation where you can see so much of hollowing and with the pigmentation coming up in the Indian scenario. So this other situation where you need to do a post-blepharoplasty augmentation with the dermal filler. As you can see here, I had filled up the mid-face along with it. I have also filled up her tail trough area and also the area in the inferior orbital rim. And the changes that you see after the procedure, as you can see here, the instant changes after the procedure. And this has really taken care of the pigmentation and has filled up the inferior orbital hollowing, which has been caused by only fat removal. And this is how she looks approximately a year after a blepharoplasty and augmentation with a fat, with a filler. But when you really have a long lid and you see the fat level is much anterior to the plane of the anterior lacrimal crest, this are the situation where you need to go a tissue preserving or a tissue adding philosophy for along with the upper lid blepharoplasty. Whereas Professor Hawate has already mentioned, you need to release the orbitomallear ligament and use this orbital fat and transpose it, make 2-3 pedicles and transpose it down up to the soup or in fact to the mid-face level, which usually gives a beautiful effacement following such procedure. Like as you can see here, this lady where you can see that it is usually done by a transconjunctival approach. But when you do a transconjunctival approach, one very important step is that you need to identify this muscle, this inferior oblique muscle, which lies between the medial and the central fat bed. And then you fashion the 3 beautiful pedicles. The longer the pedicles and the more amount of blood supply you have, it is better. And once you fashion these pedicles, you release the orbitomallear ligament. And once the orbitomallear ligament are being released, then you need to form the 3 fat pedicles that I have already mentioned. And then you can transpose it, as Professor Don has already mentioned. I also prefer in the pre-periosteal plane in such situation. And these are the beautiful changes that you can see. There's so much correction of the lid cheek junction, and the most important, the correction of the negative vector to a positive vector following the such correction of the lid. But the fourth problem, when you have a double convex deformity with the lateral canthal laxity, this are the situation where you have to tighten the lateral canthus in the form of a simple lateral canthopexy, or you can also do a lateral canthoplasty when you go a transcutaneous approach to give a more suitable appearance. As you can see here, the lower lid blepharoplasty with the 3 fat transposition along with the canthopexy giving a good result. But the most challenging situation when you have a double convex deformity with a mallear deflation and the displacement, where the gravitation force does play a role, and you need to counteract the effect of the gravity in order to give a very beautiful or a youthful face. The beautiful paper by Malley et al., which shows a 3D photography taken in the sitting and supine position, which Dr. Don had already mentioned the concept about it earlier. And you can see how gravity plays a very important role in the changes of the face as we age. Like this young girl, one face, the first photo taken in the sitting position and second in the supine position, you see the changes in the malar eminence, see the changes in the jawline, the beautiful correction of the tear trough, and also the correction of the level of the eyebrow, even without the surgery, just by overcoming the gravitation force. So in such situation, along with a lower lid blepharoplasty, you need to do a lift of the smash and also the orbicularis. And here I prefer a transcutaneous approach. As Professor Hawate had already shown, you make an incision in the skin and then you fashion the fat pedicle. I prefer excising the lower lid fat, and then you go for transposition, a pre-periosteal transposition, and then along with it, you can go for a smash lift, as you can see here. Sorry. You can see that along with it, I go a little amount of smash lift, and then you situate at a higher level, along with some amount of the correction or the lateral cantoplasty done through the transcutaneous approach. And this is the change you see, the effect of gravity that has been taken and which has been removed following this procedure. And you can make a very good correction following a simple procedure. So with this, I conclude. Thank you very much for your patient hearing.
Thank you. Thank you. That was a very nice lecture, Kasturi. Yeah. So with your technique, how often do you do your superlateral vector of lift and a supermedial vector of pull?
Yes, sir. Like
supermedial and super.
Yes, sir. It depends the fat pads. We know that see the amount of the fat pad, number one, how prominent the fat pad and how laterally it is being spread. If I say that's too lateral spread of the fat pad, then I really fashion the 3 pedicles and I use all the 3 pedicles. But if I see this, it is more mainly medially, along with it, you have a very prominent tear trough, then I sometimes use only a single fat pedicle. And regarding the lateral pull, the smash lift, those situations where you can see really a mid-phastosis. So in such situation, I prefer to do a little bit of smash lift along with the lift of the orbicularis.
Thank you. And then another question, how do you manage complications of fillers, the rare and not so rare?
So the rare complication, if I say, is the vascular complication. Touch wood, I never encountered any major vascular complication. But yes, I had bruise in 1-2 patient and which could be managed with due course of time. But also initially, like almost 10 years back when I just started the filler and I was using a needle technique, I used to get some lumps and bumps, especially in the lower lid blepharoplasty, in the lower lid filler. And then this was managed very well with the hyaluronidase.
Thank you. Thank you. So I think.
Yes, we'll move to the next topic. The next topic will be given by Dr. Yasuhiro Takahashi. He is the Associate Professor of the Department of Oculoplastic and Lacrimal Surgery of Aichi Medical University Hospital, and he is also the Vice President of our society. Today, he will give us the lectures of repeated recurrent dysthyroid optic neuropathy. Dr. Yasuhiro.
Can you see my slide?
Yes.
Can you see my slide?
Yes. Today, I appreciate Professor Rowati and the meeting staff for consideration of the date of my presentation and moving my presentation in this aesthetic session because of my work yesterday. In addition, I apologize for changing my topic to non-aesthetic theme. Today, I'm going to talk about my experience of repeated recurrence of dysthyroid neuropathy. Dysthyroid neuropathy is the most severe manifestation and sight-threatening condition of thyroid disease. This occurs in 5% of cases
Its predictors are old age, strabismus, reduced palpebral aperture, active phase of thyroid eye disease, and so on. On images, clouded orbit and compression of the optic nerve by severely enlarged extraocular muscles can be seen. Severely enlarged extraocular muscles cause optic nerve compression and following visual loss. In addition, enlarged extraocular muscles rise retrovalvular pressure, optic nerve compression, and increased retrovalvular pressure reduce blood flow to the optic nerve. According to EU GO guideline, steroid, disquizumab, eteplizumab, tocilizumab, cyclosporine, azathioprine, mycophenolate, radiation, and orbital decompression are treatment modalities. This is the flow chart of the first-line treatment for moderate to severe and active phase thyroid eye disease. If steroid treatment is not effective, we need the second-line treatment. This is a flow chart of the second-line treatment. Several treatment options are presented. This is the flow chart of treatment for distal optic neuropathy. If distal optic neuropathy does not respond to cerebral pulse therapy, we need urgent decompression. Medial or inferomedial decompression is effective for distal optic neuropathy because of anatomical proximity between the medial orbital wall and optic nerve canal. Endoscopic medial decompression has several merits compared to medial decompression via transcanalicular approach. When we perform medial decompression via transcanalicular approach, we use a malleable retractor to secure surgical field, but this causes additional optic nerve compression. This is not necessary during endoscopic approach. We can reliably remove the most posterior part of the medial orbital wall via endoscopic approach. Furthermore, we can simultaneously remove the orbital floor without axillary incision. Thyroid eye disease recurs in 5 to 15.7% of cases. Recurrence is more frequent in smokers. Possible triggers are ocular surgery, fluctuating thyroid status, life stress, pregnancy, menopause, and so on. TSAB level is correlated with activity and severity of thyroid eye disease. Our previous study showed that high TSAB activity is a risk factor of relapse of thyroid eye disease after cerebral pulse therapy and radiation. A previous study showed correlation of TSAB level with total severity I-score. Our previous study showed TSAB level and standard deviation of internal signal intensity of inflamed muscles positively and negatively correlate with risk of relapse after cerebral pulse therapy and radiation. When TSAB activity of 2,800% was set as a cutoff, predictive sensitivity and specificity of relapse were 81.2% and 90.6% respectively. Again, this is the flowchart of the second-line treatment for moderate to severe and active thyroid eye disease. In Japan, cyclosporine, azathioprine, disquizumab, and tocilizumab are not covered by insurance. So we need IRB approval for the use of the treatment, and patients should pay much money. In addition, the eteplizumab has not approved yet. How to treat recurrence distal optic neuropathy in Japan. Case 1 is a 46-year-old female. She had 1-year history of thyroid eye disease. She underwent 4 cycles cerebral pulse therapy at another clinic. She stopped smoking 1 year ago. On the first examination, clinical activity score was 4 points. Visual acuity in the left eye is 1.0, and left eyes 0.6. Color vision in both eyes decreased. She had central relative scotoma. Total value was 29 millimeters in both eyes. TSAB level was 5,180%. MRI showed inflammation in the pleural extraocular muscles and optic nerve compression. After one cycle of cerebral therapy, endoscopic medial decompression was performed. Later, she underwent additional 2 cycles of cerebral therapy and radiation. This is a CT image before decompression. This is a CT image after medial decompression. After the first treatment, clinical activity score decreased to 0 point, left visual acuity improved to 1.2, and color vision became normal. However, 1 month later, clinical activity score increased to 5 points again. Visual acuity decreased to 0.7 in the right eye and 0.5 in the left eye, and color vision decreased again. This is a face photo at that time. MRI showed pleural inflamed extraocular muscles. She underwent 3 cycles of cerebral therapy. In addition, since the dura jam was large and located posteriorly, we performed deep lateral decompression to further reduce the optic nerve compression. After the second treatment, clinical activity score decreased to 0 point, visual acuity improved to 1.2 in both eyes, and color vision became normal. Esotropia also improved, confirmed by Heschert. However, she was in depressed state. 1 month later, clinical activity score increased 5 points again. Although visual acuity did not decrease, color vision decreased. Esotropia was worsened, confirmed by Heschert. This is a face photo at that time. Heschert showed worsened esotropia. Since she was in depressive state by side effect of systemic steroid, so we decided to perform repeated triamcinolone injection into the orbit. After third triamcinolone injection, clinical activity score decreased to 1 point. Visual acuity was stable and color vision improved. Esotropia was not worsened. Her depressive condition was not deteriorated. This too was 35-year-old female. Her visual acuity was 0.4 in the left eye. TSAB level was 8,700%. MRI showed optic nerve compression and pleural inflamed extraocular muscles. After 9 cycles of cerebral therapy and balance decompression, she has still inflamed extraocular muscles. Because she could not take off from her work anymore for cerebral therapy, triamcinolone injection was performed. Now I'm following up her. In conclusion, thyroid disease and distal reticulopathy occasionally recur. High TSAB activity is a high risk of recurrence. Although EU GOGO has established the treatment guideline, we cannot follow it because of various reasons. Repeated triamcinolone injection is an option for treatment of distal reticulopathy. Thank you very much for your attention.
Thank you.
Thank you. Thank you. I have a question. What is the average time between your initial decompression and then the time of presentation of your for your recurrent or persistent compressive optic neuropathy? What is the average time or the mean time between your initial decompression?
I I have experienced several cases.
Presentation of your recurrent or
I think 6 months after decompression, the cellulite is recurred in these cases.
Okay, because you know, I read an article by Alon Kahana, and in his series, even up to 15 years, you know, symptoms of recurrent compressive optic neuropathy occurred, you know, up to 15 years following the initial decompression. So it's very important really to follow up those patients, even if they are asymptomatic. Yeah. And your TSAB or your thyroid stimulating immunoglobulin is very helpful, no? Okay. Yes. Priyamjit, do you have any other question for?
Not from the audience, but I have a question. Do you also have doing the steroid injections right after the surgery when you do decompression? I mean, local injection to the orbit.
Right now, no. When cellulite is recurred, I performed transmission injection. Not right now. After not immediately after decompression.
I see. Thank you. So, Dr. Chawate, would you introduce our last speaker?
Thank you very much.
Thank you.
Thank you, Dr. Takahashi. Anyway, I'm honored to introduce our next speaker, and he is a honorary consultant of at the Chelsea and Westminster Hospital NHS Trust, honorary senior lecturer in the Faculty of Medicine, Imperial College London, a founder member and past president of the British Ophthalmic Plastic Surgery Society, BOPSS, and a co-founder of the Craniofacial Ophthalmic Plastic Surgery at Chelsea and Westminster Hospital. Let's welcome my good friend, Mr. Naresh Joshi. Mr. Joshi.
Dr. Joshi won't be able to join us live, but we will present his video.
But I think he sent, yeah. Admin, please.
Could you play Dr. Joshi recorded video?
Hi, this lecture is entitled 2,500 Years On.
Mm-hmm.
500 years BC, Sushruta from present-day India was a reconstructive surgeon. He advocated the use of flaps for reconstruction. It is thought that his initial flap was a cheek flap. Supposedly, one of his pupils devised the median forehead flap. And it continues to this day that bosses take credit for their trainees' hard work, it seems. So we have used forehead flaps for a considerable period of time. And this has become more popular in oculoplastic surgery. In our specialty, flaps are useful for the brow, the medial canthus, and the lower eyelid, and less so for upper eyelids. Flaps can be categorized as random or vascular pedicle flaps. Random flaps need a wide base, are relatively short in length. The glabella being a well-perfused area allows for random flaps. So transnasal flaps, small, median central forehead flaps, and glabella sliding flaps work well in this area. Perfused flaps can be narrow at the base as they incorporate the chosen arterial vessel. They can be long and they're much more flexible. The vessels that we use mostly are ipsilateral or contralateral supraorbital or supratrochlear vessels. And here are some of these flaps. Here's a contralateral flap being inserted into a low defect. And in this case, I've Dopplered the vessel that allows for a 1 centimeter base and a 10 centimeter length vessel to be rotated into the lower eyelid and medial campus. A larger vessel is perfusing this long flap, which is used from the contralateral supraorbital the vascular bundle to the brow defect that you see here. Some tips regarding flap formation. Initially, mark out the template for defect. So here we're using a thick marker pen, unlike the ones we normally use, and paper is pressed onto the wet surface. Here is the defect template. This is placed on the forehead using, on this side, a contralateral supraorbital vessel. We then estimate the flap length using a cotton gauze. The gauze is then rotated around with ease, make sure there's no tension. And then the flap is cut with a 15 blade. The next is to consider the harvest of flap depth. The initial third, the distal third should be premuscular or prefrontalis, then the central third, submuscular, and finally subperiosteal for the most proximal third. This allows the vessel to be incorporated. So here you see a relatively superficial 1/3, and then a submuscular, and then finally a subperiosteal proximal third. This is then laid onto the recipient bed and the flap checked to make sure it's viable. Then consider closing the donor site. Line up the furrows. Here I'm using a 4 PDS, and the furrows have been lined up. If you should have a large defect superiorly, do not worry, this area granulates very well, as does the medial canthus and the scalp. So here it is inset, but mobilizing the forehead allows for complete closure. Next, inset the flap into the recipient bed. So ensure that not just the outer bits are sutured, but also the depth of it that allows the flap to sit in and also get vascularized from below, but also gives the contour, which is maybe concave, in this case, the medial canthus. So here's a flap which looks completely viable, sitting well, and the donor site has also been closed. So when do we divide the pedicle? Well, that really depends on a few factors. The defect size, the length of the flap, and also the patient characteristics, including if they have diabetes or hypertension. What you can do is just strangulate the vessel at the proximal end in outpatients, either with a glove or a rubber band. It's a bit painful when you do this, warn the patient. But when you do that and the area that you've reconstructed remains well perfused and vascularized, then you know that you can divide the flap. So here's a flap being divided, and you can see a clear arterial spurt. Next, some additional tips. Choice of flaps, canthal grid, over, under, through, and refining the flaps. Choice of flaps. The most commonly used flap in my service would be a contralateral supratrochlear vessel-based flap. This is a great flap and allows for great mobility and rotation, especially if you use it from the other side, because using it from the same side requires a greater turn. This is what I call the canthal grid. Imagine a line from the lateral alar to the middle canthus and one from the medial to the lateral canthus. This is a vertical line. Anything lateral to this line in the lower eyelid will require a cheek advancement flap. Anything medial, a forehead flap. So here's a defect that transects the vertical line. The lateral portion is reconstructed with cheek advancement flap. The medial portion with a tunnel forehead flap. Here's the horizontal line for the medial lateral canthus. These are just tips that you should consider and perhaps not adhere to. So anything above this line, one considers an advancement flap. Anything below, a pedicle forehead flap. So anything above So superior defects tend to do well with advancement flaps. Ones that go very low down, one should really consider a rotation pedicle-based flap. Next, we consider what we do with the flap at the base. Do we go over the glabella area? Do we go under the, or do we go through it? So the options are to just simply lay it over, to go through, or to go under. So here's a patient who's undergone an over technique. That is to say that the glabellar skin has been left intact. The undersurface of this can either be skin grafted with a split skin graft or just simply using moistened Vaseline gauze and chloramphenicol ointment. At some stage, you will need to cut the glabella to inset the flap. Here is a tunnel flap. In this case, a tunnel has been made in this area. The middle third of the flap skin has been removed, which accounts for this zone here, and the flap has been inserted. An elegant looking flap, a one-stage flap. And finally, the through. So if you have a defect like this, you may wish to simply inset it by making an incision through the skin or removing some of the skin in this area and doing a one-stage reconstruction. So the advantages and disadvantages. On the whole, I will suggest that everyone starts off by using a through technique, a single operation, a simple operation, just cut in the glabella and inset your flap, especially if you have a narrow base. And that is adequate for most people, especially elderly patients who account for most of our reconstruction. The over is also simple. And if you want to do a two-stage operation and keep the viability of the flap, this is worth doing. Warn the patients that they will need to clean the area, and it does smell occasionally. Lastly, the tunnel flap. Now, we presented this technique about 15 years ago at BOPS. We've had some strangulation of the artery due to the edema in this area. And although it's been repopularized, I would say to people that before undertaking this tunneling, which is more complex, although elegant, just be careful that you create a really large hole, a tunnel, and ensure there's no compromise to the vascularity in this area. So on the whole, I would suggest a cut through. So here's the appearance of a cut through flap, or one that required no second stage, and it gives a very acceptable result. Finally, refining flaps. Well, the distal portion of the flap should be refined, should be thin. We started out with a thinner flap in this area, but when it comes to the zones at the edge near the eyelid, they should be thinned more before insetting. That gives this sort of appearance where this area has been thin before putting onto the eyelid area. And although it looks very bulky here, a few weeks later when it settles down, it's as thin as thin. I haven't had to re-thin this again, which is different from the proximal end. This you must keep bulky because it has the vessel in it. And with time, it settles. Now, most of our elderly patients will accept this level of bulkiness and will not require any further operation. However, if they do, then you wait, you make an incision in the scar, and then you debulk that area. At this point, the vessel has been inset and well perfused, so it will not compromise the vascularity. So 2,500 years on, we continue to use flaps. It seems that those who advocated this 500 years BC, and more recently, another Indian gentleman who popularized forehead flaps about 100 years ago, 150 years ago. So really, we're no more able than those who preceded us, as it seems to be the case in many things. And we are still susceptible to the forces of nature. What I have learned over my 25 years as a consultant is that there are certain things that we value and we hang on to. And I'd like to thank you for listening to me for the last 10 minutes or so. Thank you very much.
Thank you. Thank you.
Hi, this lecture is entitled...
Anyway, I think Mr. Naras, we a ghost. Yeah. Yeah. Please turn on your video. Yeah. So yeah, and we'll take a group photo. So is everybody here? Yeah. Can you please, can we check if, so, well, yeah. Admin, please. Okay, yeah. Okay. Thank you very much to our speakers, my co-chair, Priyam, and again, congratulations, Yunia and Dongmei. It's nice to see you all virtually. Thank you.
Thank you, everyone.
Thank you, Dr. Yafate. Thank you, Pranjit.
Bye.
Bye.
Noh 3D eye prosthetic is the first fully commercial 3D printed eye prosthetic in the world. Noh 3D eye prosthetic already implemented prosthetic in 2019, combining the 3D technology such as 3D scan, 3D print, 3D design, and with human craftsmanship to bring us a fully customized eye prosthetic. The production process is relatively faster than the manual process. The fastest production record for Noh 3D eye prosthetic is 6 hours. We are only using a world-class biocompatible, inert, and certified material together with experienced professional team from ocularists and 3D engineer with supervised from ophthalmologist doctors. The process of making 3D eye prosthetic is patented since 2019. With digital iris, the eye prosthetic is more realistic and natural, combined with the depth of pupil feature that cannot be found in the manual prosthetic. For collaboration, please do not hesitate to contact us.
Good morning, good afternoon, everyone. Thank you for still joining us today in the last session. In this session, we will have 7 speakers, and each speaker will be have 2 panelists. For each speaker will be 5 minutes, and then for panelists also will be 5 minutes. After the end of the second panelist, we will have a discussion. So here I have Dr. Sani as a co-chair. Good morning, Dr. Sani. Good afternoon. Could you please introduce our speaker? Thank you.
Yeah. After thumbs up sections of lectures, our first speaker to present an interesting case is Dr. Ben Limbu from Nepal. He's the president of the Nepalese Society of Oculoplastic Surgeons. And for our panelists for the first presentations, we have Dr. Hernawati from Indonesia, the currently consultants from Jakarta Eye Center, and Chair Professor Dong Kikawa, the Chair and Professor of USC San Diego Department of Ophthalmology, and Shirley Eye Institutes in La Jolla. We have Dr. Ben Limbu, please.
Thank you very much. Good morning and good afternoon, everyone. Is my slides visible here?
Not yet.
Not yet?
Not yet, yes.
Sorry, I'll try it again. Yeah, I think it's coming up now. Is it visible now?
Yes. Yes, yes, good.
It's visible. Yeah. So I would like to thank Dr. Dongmai and Dr. Yunia for letting me this opportunity to present today. So I declare no financial interest on my presentation. Just brief about the introduction. Blaskowitz started in 1923, the levator resection, and it's one of the most effective procedures to address ptosis surgery with success rate of 70 to 95%. The good thing about this surgery is we can always add more other.
Dr. Ben, your slides is not moving. We are seeing your original PowerPoint slide.
Yeah, can you see that?
We are still seeing your normal PowerPoint view, so not the presenter view.
Let me one more time stop the sharing and let me try. Sorry for that technical problem. Are you able to see it now again?
We can see the PowerPoint, not the slideshow.
It's not moving now?
No, we're seeing your first slide, success tricks.
I'm sorry. So, admin, can you just check why my slides are not moving? Because I can see on my slide, it's moving on my side. Someone can assist me from the admin? Or should I try again resharing it?
Dr. Ben, can you stop sharing and we will share your slides from the admin? Thank you.
Yeah, thank you.
Admin, please share the slide.
Sorry for that. Yes, this one, yes. We can continue with this slide. Thank you. Yeah.
Okay.
Thank you. Thank you very much. So the good thing about this surgery is we can always add the adjuvant procedures like addressing the dermatochalasis in our procedure. But the bad thing about this surgery, it has a longer time of recovery. So can you go to the next slide? Yes. So the utmost thing that we need to consider is a preoperative evaluation to have a better outcome after the surgery. So we need to consider interpalpebral feature height, levator palpebral superior function, and even the MRD and lid crease height. Ice pack has to be done, Bell's phenomenon, orbicular stone, Surma test, corneal sensation. Apart from this, we need to see for the canthal supports, how the canthal support is behaving in the patient. And apart from that, we need to also see for some systemic diseases. Other thing that is most important is, apart from the preoperative evaluation, is your anatomy. We need to go layer by layer. So we need to start the skin incision and then the orbicularis, and then finally the septum. And then, of course, can you go to the next slide? And then we can see a fat here. That's very much important to identify the levator. And once you identify the levator, try to test always for the post-doxon test on the muscle. And then once you do that, then separate it from the molars and then free it from the molar. And then finally it attaches to the tarsal plate. Can we go to the next slide? That's some of the important thing that we need to consider. This is a congenital ptosis with a fair levator function, and this is what we did on our surgery. Next, please. I'll go through some of the cases. This is another case, again, congenital ptosis with very poor levator, and then we did a levator resection. Still, it worked. Next slide, please. And this is one of the traumatic patients. He had a blunt trauma in his eyes, and his levator was fair, and then we went to levator resection, and that's what it looked like. Next slide, please. And this is another case of allergic conjunctivitis, vernal keratoconjunctivitis. She had a ptosis with a good amount of levator function, and we did a levator resection. This is how she looks like after the surgery. Next slide, please. This is a prosthesis patient who has constant rubbing of the levator, but levator function was good, and there was a ptosis, and we did consider ptosis surgery, levator resection on this patient. Can we go to the next slide, please? And can you play a video of this for me? Yeah, thank you. So this is one of the video to demonstrate how we do levator resection surgery. So that was under local anesthesia. So incision over the skin, precisely over the skin, and then orbicularis was incised, and then levator was, the orbital septum was identified and of course open, and then finally we identify the levator and then attach it to the, so we can see here now the levator was rolled back. So we try to identify the levator and then try to bring forward and push back the fat pad there. So fat pad identification is very much important to realize and recognize the levator muscle here. So while dissecting it from down, we need to be very careful not to perforate the conjunctiva. And then we can always test for the togging of the levator muscle, and then finally attach it to the tarsal plate. Next slide, please. So please skip the video for the time purpose. So this is the patient who came with the bilateral ptosis, and I did subsequent two-stage procedure for both eyes, and then this is how the outcome looks like. And thank you very much for hearing me for last 5 minutes. And then most important thing, I feel my personal experience is that preoperative evaluation is the most strong thing that we need to consider. And then we need to know a better anatomy on the eyelid. All the time, we cannot see the fat pads that I have shown here in the pictures. There are certain times when you don't see the fat pad, but still you need to search for the levator. That's one of the most important things to get a good success in levator resection surgery. Thank you very much.
Thank you, Dr. Ben. The result is very good. I will continue with the first panelist. Would you please, Dr. Hernawita?
Good afternoon, all my colleagues. Thank you for Dr. Darmayanti and Dr. Sani as moderator, and thank you for Dr. Ira Yunia and Dr. Dong Mei for inviting me to participate in the commentary section. In this opportunity, I have to give a comment to presentation of Dr. Ben Limbu and answer the question from him. Dr. Ben Limbu.
Yes, yes, madam.
Ini kok nggak mau sih? Wait. You have already solved several cases of blepharoptosis with.
Please unmute. Please unmute.
Dr. Ben Limbu, you have already shown us several cases of blepharoptosis with different etiology and have been performed levathoresection surgery with good result, as we can see in the picture. But I want to know about, do you have any guideline, special guideline? I mean, how much you have to do the resect of the levator of your patient? Do you have any special guideline in this patient?
So, these patients are done under local anesthesia. So I usually tend to adjust the height of the levator section according to the contralateral eye on local anesthesia. So basically to say there is no any guidelines, exact guidelines to correct the ptosis on these patients. These are all adjusted on the table.
Okay. So in my experience, my experience usually usually we use the guideline from American Academy of Ophthalmology or Smith procedure. From AO usually it depends to the degree of ptosis and levator function. But for Smith procedure usually we do the resect difference between ML normal and the ML ptosis multiplied by 3. And if I do the apoptosis levathoresection under general anesthesia, usually if the levator action 5 millimeter, usually I put the eyelid margin 1 millimeter below superior corneal limber. If the levator action 6 until 7 millimeter, usually eyelid margin 2 millimeter below superior corneal limber, and if 8 until 9 millimeter, I did eyelid margin 3 millimeter below superior corneal limber, and levator action more than 10 millimeter. I put the eyelid margin 3 until 4 millimeter below superior corneal limber. Kok ini lagi sih, nggak mau lagi kenapa? So I want to know about the post-operative complication of your patient about lid lag lagophthalmos. Is there any complication? Because in your presentation, I didn't see about that.
Correct, ma'am. Normally, lagophthalmos would be there for the patients with levator resection, especially with the poor levator function. I see much lagophthalmos, but that would go away within 2 weeks to 4 weeks of time. And that doesn't, I have not seen any patient who really has exposure keratopathy because of lagophthalmos till now.
Okay. And the second, I have to answer your question. The first question, would you like to perform LPS advancement in a patient with good function among myasthenia gravis? As we know, myasthenia gravis is an autoimmune disorder which the body's own antibody block the transmission of nerve impulse to muscle, causing fluctuating weakness and muscle fatigue. And blepharoptosis is the first sign of myasthenia gravis. About 50% of the patient myasthenia gravis experience of blepharoptosis. So the first line of treatment of myasthenia gravis, usually medical treatment. The first acetylcholinesterase inhibitor like pyridostigmine, bromide, neostigmine, or corticosteroid. Short term, corticosteroid is very effective, but in long term, we can find adverse effect. And immunosuppressive therapy, for example, azathioprine, cyclosporine, and MMF. If the medical treatment not effective and the patient intolerant of medical treatment side effect or both, usually surgical intervention is the option. That's why in my criteria of surgical intervention in myasthenia gravis patient, if the patient stable general condition, at least 2 years have a medical treatment by neurologist or neuro-ophthalmologist, but the patient still experience blepharoptosis. And of course, if quality of life severely disrupted by blepharoptosis. And if there is criteria, we found to the patient, I did the levator expansion in the patient with myasthenia gravis. And surgical procedures are the same with those used for blepharoptosis without myasthenia gravis. For example, if levator function poor, less than 4 millimeter or same 4 millimeter, I did by frontalis suspension, where if the levator function more than 4 millimeter, I did levator expansion or resection. But in some patients, although they have already get their levator excision, I beg for the patient to use the medical treatment too. And the second question, do you complete your levator surgery if last hematome in levator muscle occurred during surgery, or you postpone the surgery? Actually, I almost never have experience about during levator muscle surgery. But if it happened, I think I will postpone the surgery. That's why I think my suggestion to prevent the hematome during the surgery, it's better the patient have to stop antiplatelet medicine for 1 week before surgery and perform the laboratory examination, especially hemoglobin, clotting time, and bleeding time. Then the result must be normal. If not normal, I think I didn't do the surgery until the laboratory examination is normal. Yeah. That's all my comment for the Dr. Ben Limbu. Thank you for your attention.
Thank you very much, ma'am.
Thank you, Dr. Hernawita. I think we will proceed for the second panelist, and then we will discuss.
Kenapa sih nggak mau?
Please, Dr. Don Kikawa.
Thank you very much. I want to congratulate Ben Limbu for an excellent talk, excellent results. I just wanted to say, echo what Calvin Chong said. Ptosis is arguably one of the most common oculoplastics procedures, and what makes our specialty unique, and that we're the only field that really specializes in ptosis surgery. We do need both precision and accuracy with ptosis surgery. Both anterior and posterior approach as well work well. And for those of you who don't use the posterior approach, I encourage you to learn it. And for us to get better, we have to be critical of our own results and examine them. What lifts the lid is always kind of the big question. And the traditional thinking is that the levator is the main lifter and Mueller's provides an additional 2 millimeters of lift. I do want to say that the contemporary thinking, at least the way that I've kind of viewed this, is that the levator is still the main lifter, but Mueller's provides the main attachment and is dynamic in function. So think of it as the levator as the locomotive, but what couples the locomotive to the rest of the train is Mueller's muscle as viewed by this coupling link. And as the lid gets stretched out, that coupling link needs to be tightened. The three important endpoints of ptosis surgery: one is lid level, one is contour, and one is symmetry. And excellent levels can be achieved with levator surgery, as seen in this patient who had left upper lid ptosis repair. Sometimes the level is not so clearly sorted out so early. This is a patient who had left upper eyelid ptosis, underwent surgery, and at about the 2-week level, we can see that, well, maybe it's going to be a little lower than what we anticipate. We do give it some time, and we do see that the lid comes up. However, it's still a little ptotic, and maybe the contour is not ideal. Contour for levator surgery is best accomplished with placement of the sutures. And you can see here in this patient who had an excellent result and was happy with the result, perhaps her lid level was slightly peaked laterally, indicating the suture was placed too far temporally. One of the other modifications of the levator technique I'd like to share is the small incision surgery. This was first reported by Dr. Mark Lucarelli and Dr. Brad Lemke. And here's a brief video showing the technique. This is a small incision, about 8 to 12 millimeters in length. Incision is made through the skin. Cutting cautery can be used to expose the upper tarsal border. The conjoined tendon is then grasped where the levator and septum fuse just above the tarsal border. The levator edge is clearly identified. And then the levator is advanced with a 6-0 proline suture with a partial thickness tarsal bite at the upper tarsal border about the junction of the upper third and the lower 2/3. This is tied in a horizontal mattress fashion and tied temporarily. And then the patient is asked to open their eyes intraoperatively, and the level is then adjusted. You can see there's good contour and level with one suture. This is a patient who underwent bilateral upper lid small incision levator surgery. So some of the questions for Dr. Limbu: how many sutures do you place? What type of suture do you use? How do you set the level at the time of surgery? Do you set it at the desired level? Do you overcorrect? Do you sit patients up to adjust them? And then what is your threshold for revisions? Do you perform revision early or late? And what % of revision rate do you tell your patients? Thank you again, and congratulations on a very nice talk.
Thank you very much for the comments and question. So I think there are 3 questions that I need to address. So one was like what suture I use. I used to use 6-0 Vicryl before, but now I started using 6-0 proline for my patients. And then I use only single suture technique to address the ptosis. I don't use 3 sutures or 4 sutures unless and until there is a big lid contour deformity. I sometimes adjust. Otherwise, I give only a single central suture to address, that's 6-0 proline to address the ptosis surgery. And I do not take patient upright position and then see it normally. But what I do is I overcorrect by about 1 millimeter at the table for all the patients under local anesthesia. And then, then last question was about, sorry, what was the last question? Can you?
Sure, the last question was about revisions. Do you
perform
early revision?
I definitely, of course, tell my patients that the revision rates are about 15%. So 85% success rate and then 15% failure. And if that happens to my patient, I usually recall what I did when I was operating for the first time. If I feel that levator is not good in the patient on the first attempt and then the patient asks for revision, I usually tend to defer the surgery for levator resection. I better go for frontal sling on those patients. But usually I try to convince the patient to stay for at least 1 month, 2 weeks to 1 month at the earliest to reoperate for ptosis. Thank you.
Great.
Thank you
very much.
Thank you for all the speakers. Dr. Don, do you always do one surgery, one fixating for ptosis or ptosis, even severe ptosis?
Well, that's a good question, Dr. Sissoy. I usually try to do one single suture centrally, but if there is a contour abnormality, for example, if the patient has a floppy tarsus and you can't get good level with one suture, then I will extend the incision and place additional sutures. So for acquired ptosis, I would say I usually use one. If it's congenital, I usually put 2 or 3 in.
Okay, thank you. And for in patient with myasthenia gravis, do you perform surgery also? For myasthenia gravis, Dr. Ben Limbu asked to us. Myasthenia gravis, do you perform levator? Do you perform ptosis correction?
Yes, I think this involves co-management with either a neurologist or neuro-ophthalmologist, and patients usually need to be treated medically. And it certainly depends on what type of levator function they have. I think usually the levator is not, does not have normal function, so I prefer to perform a sling if necessary. And I usually use a silicone band because it's adjustable.
Thank you very much. Dr. Sani, do you have any question?
Yes, we have one question from the audience. In case the patients have prior blepharoplasty or ptosis surgery with much of the pre-aponeurotic fat removed, any tips on how to identify and find the levator?
Well, I usually will, try and grasp the tissue and pull inferiorly. And if I am really unclear which tissue plane I am grasping, I have the patient look up, and then you can usually feel some tension. If you're just grabbing the septum, then usually you don't have any movement. So that's usually the best way. Particularly sometimes you see the conjoint fascia very high up in the fornix. So I think the best way is just to have the patient look up, and you can usually feel the tension.
Thank you. Because of the time constraint, we will do the rest of the question and answer later or online. Our second presenter is Dr. Priyamjit Sananon. She is the director of the Sananon Clinic in Bangkok. And for our second group of panelists is Mr. Joshi from Chelsea and Westminster Hospital, as well as Professor Ip Chiu Chiu, who is the head and senior consultant of Khoo Park Hospital in Singapore. Dr. Priyamjit, please.
Good morning. Thank you for having me in this webinar. Today, I would like to present a case with sunken eye. This is a 64-year-old female patient presented with droopy eyelid and want to change her eyelid appearance. She stated that she had single eyelid when she was young and got the eyelid fall when she got older without any previous surgery and trauma around the eye. Her MRD1 was 1 millimeter for the right and 2 for the left, and the levator functions was 11 and 12. There was an eyelid crease on the right, but only faint crease on the left. Dermatochalasis and sunken eye was prominent both sides with high brow position. After installations of 3 new ephrines, the MRD1 was 2 and 3 millimeter. So I advised her to first underwent external levator advancement with pre-aponeurotic fat transposition, and later subbrow blepharoplasty to correct the temporal skin hooding. But during the first operation, only scant amount of fat was identified and could not be transferred. 1 week after external levator advancement, her MRD1 was 2 and 3 and looked less hollow. But 1 month later, after the swollen subsided, the sunken eye apparent was still prominent, and the MRD1 of the right eye was not satisfied. So she underwent subbrow blepharoplasty with roof or retroorbicularis oculi fat transposition for both sides and revised external levator advancement on the right. This video shows my technique of roof transposition. Not in the same patients. For these patients, the upper blepharoplasty was also performed at the same time to correct severe dermatochalasis. First, the incision below the eyebrow and the skin and subcutaneous tissue was removed. Then the orbicularis oculi and roof was created as a flap, same size with the subbrow skin excision. Then I create a pocket just anterior to the orbital rim for the flap. Derma was used to identify the superior orbital rim to secure the flap with 5/0 PGA sutures. So the flap was flipped and secured with the superior orbital rim. Then the flap was positioned well in the pocket by the rear periosteal elevator. The orbicularis oculi suspension was performed to the superior orbital rim, and then the wound closure, first with subcuticular stitch and then the skin closure. And this is the immediate intra-op photos after both subbrow and upper blepharoplasty was performed on the right eye. Come back to our patients. This is 1 week post-operation. Compared to the preoperative photos, her eyelid appearance was better. However, due to COVID-19, she still not come back for follow-up. So I still haven't seen the real result of the operation yet. Here's the questions for the expert. I would like to know your current approach and management for sunken eye and hollow socket. And if more than one causative factor present, will you correct it at the same time or stage approach? And the last question is, what is your preferred method for volume augmentations for the upper eyelid area? Thank you. Good morning. Thank you for having me in this webinar. Today,
can we have Professor Yip Chiu Chiu and Mr. Naresh Joshi?
I think Dr. Naresh is the first panelist, right?
Following the surgical video, I've been asked to make a comment on these 3 points. Correction of the subbrow unit hypervolemia. Should this be a single or stage approach? And how do you augment the orbit? Well, to answer the second question first, if possible, do it in a single setting. If not, adding volume sequentially is not an issue. How do you correct the hypervolemia? Well, if possible, correct the cause. And the 3 principal causes: deflation or retroplacement of the subbrow tissue, elevation of the brow, an expansion of the orbital bony cavity, or intraorbital volume loss. And here are the treatment modalities for deflation, brow elevation, and orbital bony expansion. Firstly, with fillers. It's easy to use and it's reversible. The disadvantage is that it may migrate. Secondly, autologous fat graft. It is permanent. It is a more complex procedure to master, and it is almost irreversible. The options for autologous fat graft is advancement of the pre-aponeurotic fat pad, where possible, redistribution, often from the medial fat pad to the pre-aponeurotic area, fat pearl grafts taken in globules, or injection of fat. The injection can, of course, be micro or nano fat grafting. The micro in the suborbital orbicularis region and the nano in the subseptal, both avoiding the pre-tarsal unit. For compensatory or over-elevated brow, which causes deflation, either botulinum toxin or ptosis correction. So mild overcompensated brow elevation can be reduced in height, resulting in more volume in the subbrow unit. When it comes to ptosis, this often results in hypervolemia with brow overcompensation, and correction of ptosis, advancement of pre-aponeurotic fat pad, results in a degree of brow ptosis and therefore more volume to this area. Occasionally, both may be required, ptosis correction, fat volume advancement, and botulinum toxin to add volume to this hypervolemic subbrow unit. We know from studies beforehand that there is an expansion of the orbital bony cavity, but also intra-orbital volume loss. And this can be corrected with volume augmentation. And here's a case where hypervolemia and hyperglobus has been corrected adequately from an insert in the inferior orbital rim, but has also corrected the hypervolemic subbrow unit. With regards to the surgery itself, I have no experience myself with this technique, but to comment, maybe the volume may be inadequate with this flap. I would be concerned about the mobility of the flap with eyelid excursion. It may lower the brow itself with resection of skin in this area and may raise the lateral skin crease. And you may have hypervolemia at the donor site with puckering of the skin above. But I look forward to the results of this in the future. So I hope I've answered the questions asked of me. Thank you very much for allowing me to speak to you today, and very best wishes for this conference.
Recording
Good
stopped.
morning. Thank you
Thank
for
you,
having
Dr.
me in
Naresh.
this
And the
webinar.
second
Today, I would like
comment
to
from
present
Dr.
a
Yi,
case with
please.
Sangen.
Yes, I will share my screen now. Can you see my screen?
Yes.
Yes. First, I'd like to thank Dr. Yunia and Professor Li Zhongmei for the kind invitation for me to a panelist to comment on this case. So basically, this is a case to discuss how we can rejuvenate the upper eyelids. I have no financial interest to disclose, and I appreciate no photography or video recording to protect all my patients' confidentiality. So, Dr. Salnana presented a case of a very deep superior sulcus with concomitant ptosis with a residual deep sulcus after a ptosis correction. And she did a subbrow blepharoplasty as well as a very novel approach to transpose orbicularis and the roof fat onto from the lateral aspect to cover the superior sulcus. There's some, I'd like to commend her for some of the good positive points about this surgery is that the use of autologous tissue, although there's some modest filling of the sulcus, and also this is a vascularized flap with good blood supply, and also the subbrow will seem to heal very well. However, there are some concerns as just Dr. Naresh has brought up just now, that the sufficiency of the tissue to volumerize, especially over the medial compartment. You're moving something from lateral to medial. And also there's, looking at the photo, there may be a little bit of flattening of the eyebrow contour and also possible descent with the roof fat being pushed down and medially. There may be a descent of the brow to probably exacerbate any eyebrow ptosis. And also this may mean that it may not be so applicable in patients with eyebrow ptosis. And also with the surgery around, there may be subbrow adhesion that may limit eyebrow movement. And also we are unsure about the long-term results. So how I see rejuvenating the upper lip sulcus, we should look at it as an eyebrow and eyelid continuum. The orbital separates the fat compartment into the orbital fat as the pre-eponeurotic fat. In front of the septum, you have the preceptor fat and the roof fat as a continuous layer. And this preceptor fat is sometimes also called the submuscular fibrovascular adipose tissue as described in Kakizakis's paper. And the fat is not only to add volume, but to act as a tissue-glide plane. So as you know, that some patients may have already a pre-existing deep sulcus even since young because of very prominent orbit or deficient soft tissues. However, many a time, as in this patient, is likely due to a senile cause whereby there is either an unbalanced bone absorption or most commonly due to a weakening of the lobwards ligament, causing what we call a Rolex phenomenon, whereby a distribution of the orbital fat towards the inferior compartment, resulting in a sinking of the superior sulcus. Now, of course, the iatrogenic causes like surgery and trauma, and not to forget some of the glaucoma medications that we treat. And certainly, ptosis is a cause of a deep superior sulcus. As you know, that especially with aponeurotic dehiscence, right, there is a superior posterior migration of the pre-eponeurotic fat pad and worsened by the elevation of the eyebrow to make the upper lip sulcus even more obvious. And also in Asians, there's this tissue described as a preorbital septal fiber, which actually limits the herniation of the pre-eponeurotic fat. And one surgery is done to actually, this paper report that releasing this will actually allows the orbital fat to move forward to correct the the deep sulcus. And we're not very sure what this is, but we're not sure whether it's a ligament posterior septum or a lower position called transverse ligament as described in Kakizaki's paper. So a systemic review involving about 680 cases, very nicely reported by Moon, showed that most of the surgery then reported is replacing fat, either in the form of fat grafts or some sort of fat injections. And in some cases, and also the reports of using fillers instead of using autologous fat. And also there are some surgeries some reports about relocating the own fat, the orbital, the pre-eponeurotic fat. And also in patients with ptosis, there's also a report of advancing levator. As we know that I mentioned just now, the advancing the levator, as in this case, there's no cutaneous incision, just a conjunctival mulerectomy. Post-op, you can see there's a lowering of the eyebrow, normalization of the crease, and importantly, you can see the softening of the upper lip sulcus. However, when fat is deficient, you will need to volumerize the deficient fat compartment, and it's been reported either to use your own pre-eponeurotic fat or the use of autologous fat grafts, such as from the dermis fat graft, facial fat, and umbilical fat. And also there have been reports of using acellular dermal allografts. And autologous fat, I think he has been mentioned just now, basically to inject it very deep into the preceptor compartment. And fillers, I think there have been previous speakers who talk about it, basically again, inject deeply along this region here. And relocating fat, I will favor this because this is using your own fat. When doing a levator advancement, you can know that the pre-eponeurotic fat is moved down. But also when there's not sufficient, you will need to further relocate the post-septal fat, either in the form of transposition or advancement. John reported the use of transposing fat, and Chen had reported 250 cases whereby the advanced and median lateral fat pads down and stitching down to the levator aponeurosis. These are some of my personal cases. This patient has dermatochalasis, eyebrow ptosis, and deep sulcus, and was treated with a blepharoplasty, internal browpexy, and septal fat advancement. I did release the preseptal fiber. This shows some result before, 1 year after primary gaze, down gaze, and also at the right oblique, left oblique view, showing a nice refilling up of the superior sulcus and also a relaxed frontalis. And also on top of relocating the fat, when there's deficient roof, they also augment the roof fat with either thigh fat injections or umbilical fat injections. Most of these surgeries are generally very safe. In a big review by Moon et al., they show that there was very low complication rate, as stated here, only about 7.2%. Less than 5% required reoperation, and there were no cases of tissue necrosis or vascular occlusion. So in conclusion, you need to really evaluate the severity of the deformity and the periocular anatomy, diagnose coexisting preocular pathology to correct them, like ptosis, eyebrow ptosis, and the choice depends on the severity, the pathology, the patient's choice, and the surgeon's experience. And the surgery is either to relocate, you have sufficient fat, or it is insufficient to add fat, and correct other coexisting pathology like ptosis, and you need to customize the volume, the site of the filler of fat injections. You need to have an individualized treatment plan, and the ultimate aim is to restore the contour of the brown eyelid continuum without compromising function. Thank you very much for your kind attention.
Thank you, Dr. Yip. So we know several procedures to correct the deep superior sulcus. Maybe Dr. Sani, would you have any question there?
Yes, I want to congratulate Dr. Priyanjit for utilizing the tissues. Just one simple question to ask. Since you are going to reoperate on the right side, if we just say that the patients have one-sided ptosis, residual ptosis, would you just to do suborbicularis dissections all the way up, same as internal brow fixation kind of technique to free up the roof, or you will still prefer now this additional subbrow incision? Because the concern is we know that the eyebrow need to be dynamic. Subbrow sometimes may not be an acceptable scar, and occasionally after the dissections, we also worry about the eyebrow adherent to the orbital rim, and then it becomes a static situation. If it's just one-sided, for your case, it's because it's both sides and you only need to do the ptosis adjustment on the right. But so one-sided, would you choose your incision differently?
Thank you, Dr. Shen, for the questions. Actually, for the subbrow blepharoplasty, I feel that most oculoplastic surgeons feel very reluctant to perform these procedures. Actually, I know this procedure for more than 10 years, and Korean plastic surgeon, they perform it a lot. But I just start doing it for like for 5 years, and actually it's very good procedures. I have to say that it's correct many patients' problems. And when I advise patients, most patients, they prefer the scar here beneath their eyebrow more than the eyelid. And if you have temporal hooding and you have to extend your scar to the lateral corner of the eye, that is very visible compared to the below the eyebrow, especially when they have thick hair or they have tattoo for their eyebrow. So for me right now, if the patients already have eyelid crease and I want to correct the redundant skin, even for one side, I still prefer the subbrow surgery. And I haven't had any patients who complained about they're unable to move their eyebrow, because what we fixed, we didn't do anything with the eyebrow. We fixed it below the eyebrow. So the tissue above it still can mobile.
Yeah, I agree with Primajit. So a subbrow blepharoplasty advantage is you can correct the lateral hooding nicely. And importantly, I think because you do not actually remove the skin above the crease, right? What happens, you remove the skin, the typical blepharoplasty, now the thicker skin on the upper part of the lid is actually coming down. So this actually gives a very natural. However, if you do have need to modulate the crease height, or you need to do ptosis surgery, then this may not be suitable. I think it's you need to be very selective in your indication with a subbrow blepharoplasty, making a subbrow incision. Yeah,
you're right.
Thank you, Dr. Priamjit, Dr. Nares, and Dr. Yip. I think we will continue to the third topic.
Yeah.
Please, Dr. Sani.
Our third presenter is my dear colleague, Dr. Stephanie Yong, who's the Director of Ophthalmic Plastic and Reconstructive Surgeries of Eagle Eye Centers. For our third group of panelists is Professor Rohit Sajid, who is the Professor of Ophthalmology of National Academy of Medical Science, as well as Professor Wei Lu of the OPRS unit in the Second Hospital of Dalian Medical University. May I have Dr. Stephanie?
Hi, good evening, good afternoon, everyone. I'll share screen from my side now.
Recording in progress.
Can everyone see my screen?
Yes.
Okay. Thank you, Dr. Yunia and Professor Lee, for this kind invitation. It's been a real treat and privilege hearing all the speakers before me speak, and I'm really learning a lot from all the experts. So I have no financial interest. I'd like just to acknowledge Dr. Liu for referring this case to me. She's a pediatric ophthalmologist in Singapore. So our patient is a 10-month-old Japanese boy seen by the pediatric ophthalmologist. He has no family history of blepharophimosis, but he clearly has features of blepharophimosis. You can see that he has horizontal shortening of his palpable apertures. He's got ptosis with poor levator function. He's got epicanthus inversus and telecanthus. So the main concern really was about his amblyopia. He was first seen at 2 months. He had central fixation that was steady and maintained, and a refraction of +4 diopters. However, at 4 months later, at 6 months old, the pediatric ophthalmologist noticed a myopic shift with increasing astigmatism, and he was now plano with a high cil. And this patient was also screened by a geneticist. The parents were really concerned about it because none of them had any family history. The FOXL2 single gene testing was negative, so this is quite rare. Most BPA, from what I understand, most blepharophimosis syndromes are associated with a FOXL2 gene mutation, and so the geneticist suggested the next step to be chromosomal microarray or whole genome sequencing. The father was really keen to identify the underlying genetic basis for future reproductive planning as well as for the patient's own future risks. So the first part of the questions to the expert is just pre-surgery. Do you do genetic testing for blepharophimosis? Is there any significance if the gene's negative? Is there an ideal age? Because this patient is really young at 10 months old. What's your lowest age limit? And would you perform stage surgery? So when I was first referred this case, I was really uncertain because we've all been taught traditionally to do a 2-stage surgery, correct the epicanthus first, relieve that tension, and then later on do the ptosis surgery. But in this case, the main indication for referring was really the ptosis that was causing amblyopia. But after listening to Dr. Damayanti's excellent talk on blepharophimosis yesterday, I'm now more confident that I made the right choice to do a combined stage procedure. So markings, these are the markings. So the markings were made as seen here. On the epicanthal fold at the desired position. This has been published by Dr. Ho Sok and Prof. Wu and Prof. Kim in ophthalmology. So I know Dr. Damayanti used the VY plasty and she had excellent results, but in East Asian patients, we know how badly the medial canthus scars. So this redraping technique has been quite useful, not just for our cosmetic epicanthal plasties, but even for blepharophimosis. So I used it for this case. And then the nasal skin was pulled medially to expose the lacrimal lake. And another point marked just nasal to the medial canthus, and then the straight line was drawn between these 2 points and extended laterally in a subciliary manner, aligned to the center of the pupil. The skin incision was made along the markings, the flap retracted. So similar to a cosmetic epicanthaloplasty, there's a lot of dissection, but the dissection here must be a lot more aggressive. And really that dense fibrous tissue and excessive orbicularis muscle between the skin and medial canthal tendon must be removed. And this will allow the epicanthal fold to be diminished and allow skin flap to be draped. And very importantly is that the medial canthal tendon must be identified and shortened via application using 250 Prolene sutures, as Dr. Damayanti did mention yesterday. So the first stitch is at the insertion of the medial canthal tendon at the frontal process of the maxilla, and the second stitch at the lateral portion of medial canthal tendon. And we try to make this stitch, this vector, more posterior. So this is after the right side is done. We can see that the epicanthal fold, inversus epicanthus has been relieved, and there is more angle to the medial canthus. And this is after both sides have been done. And then we proceeded with the frontalis sling. We weren't confident of getting enough fascia lata from the patient, so we used preserved fascia lata. We used the full incision on the upper lid and the Fox pentagon technique. This was as far as I could stretch the lids. Probably there was still a lot of tension. This is him at post-op day 1 and post-op week 1. And this is him at 1.5 years old. So I apologize, it's not the best picture. It was taken by the pediatric ophthalmologist. There's still some mild to moderate ptosis and prominent epicanthi, but he does look like a normal East Asian boy. And definitely the parents are happy. He's returning to Japan and they need to change the passport. So this is him 6 months later, pre-op and post-op. The second part of my questions to the experts are, would you correct the slight residual ptosis in epicanthal folds? If so, when? Would you have chosen the same surgical techniques? What would you have done differently for better outcomes? I know there's some discussion about medial canthal wiring, but what's your take on that? So thank you. This is a summary of the questions again. Pre-surgery, about genetic testing, any significance if the genes are negative, what's your ideal age, to correct them, and would you perform 1 or 2 stage surgery? And then post-surgery, what would you have done differently? Thank you.
Thank you. Thank you, Dr. Stephanie. I think we proceed with Dr. Rohit, please, for first panelist.
Just 1 second, I'm sharing the slide. Do you see my slide there?
Not yet.
Wow, really? What about now, Dr. Damayanti?
Not yet. Not yet. You see your slide?
How can I share?
Would admin be able to help?
Oh. So then, shall I speak without slides?
Dr. Rohit, does the admin have your slides? Maybe they can play it for you.
I don't think they have because I didn't send to them.
Okay.
Yeah.
Okay, you can speak without
Okay.
slide up.
So first of all, I would like to thank you, Dr. Dharmayanti, and my friend Dr. Sunny, having in this session, and would like to heartily thank you, Dr. Yunia and Dr. Dongmai, for the excellent Galaxy of Asia Pacific expert in the arthroplastic session. I do not have any financial disclosure and got the permission. I didn't have to say this one. The surgical indication for the blepharophimosis syndrome is basically to improve the vision and to give the good outcome in the cosmesis. So these are the two main indications. And in your case, as the boy was 10 months old, the most important thing to consider whether he is amblyopic or not amblyopic. If he is not amblyopic, as you have stated, that it's orthophoric with the steady head posture and with the comparatively good vision, then we don't have to bother much about that. The ideal age for the correction of blepharophimosis syndrome is, say, 3 to 4 years, as by the time the patient can pre-operative evaluation omit, the way to follow the instruction, and the post-operative management could be easy to perform. And the pre-operative requisites to perform the blepharophimosis syndrome are the accurate measurement of the following things: interpupillary distance, intermedial canthal distance, horizontal palpebral fissure, vertical palpebral fissure, distance from middle limbus to middle canthus, distance from lateral limbus to lateral canthus, and usually the normal intermedial canthal distance is half of the interpupillary distance. So amount of correction of the telecanthus is equal to the half of the full preoperative intercanthal distance deduction with half interpupillary distance. So for example, in your case, interpupillary distance is 60 millimeter and intercanthal distance looks like 40 millimeter. The desired intermedial canthal distance is 30 millimeter. So amount of correction on each side will be 5 millimeter in each side. Sequence for my surgery to your patient would be the first lateral canthoplasty. I would like to add the one more surgical steps for the patient is a lateral canthoplasty, then medial canthoplasty, and then followed by frontalis ring surgery. Lateral canthoplasty will give 5 to 6 millimeter widening of the horizontal palpebral fissure. And you do the lateral canthotomy, then the dissection of subconjunctival fornicial conjunctival dissections, and put the 3 sutures, central sutures in the newly formed lateral canthal angle in mattress fashion, and interrupted suture superiorly and inferiorly with 6 of eyelid. There are many choices for middle canthoplasty as Hornblast CU plasty, YV plasty, Roveda procedure, and Mustarde double jet plasty. And my choice of middle canthoplasty correction is YV plasty and Roveda. I used to use Roveda procedure for many years and found very effective and very nice. And as well, I started switch on to the YV plasty, also equally good. So I'm sorry that I couldn't show the diagram made on your pictures, but anyway, in Roveda procedure described by Argentinian ophthalmologist, you will make the triangles coming from the middle canthus toward the nasal bridge, and the nasal triangle again divided into 2 flaps and cover the superior and inferior part of that triangle, and then reoppose and transpose that. And YV plasty also equally good and very simple. Another explained technique for middle canthoplasty is CU plasty. Almost the principle is almost same, but you will have the 2 curved shape C and U shape. During the middle canthoplasty, so after giving the incision and subcutaneous dissection, you will expose the orbicularis and fibrous dense tissue. You excise them very nicely and expose the middle canthal tendon. Then you do the plication of middle canthal, taking the bite, first bite at the insertion of middle canthal tendon in the anterior lacrimal crest, that is the frontal process of maxilla. Then they continue that bite to the middle canthal nearby your incision to the middle canthal angle and keep the good suture with the help of fiber polyester or protein is quite good suture to take these bites. And then close the wound in the layers, orbicularis with 6-O-Vicryl and skin closer with 6-O-Silk or protein. The next step is tarsofrontalis suspension sling surgery. The material have been used fasciolata, silicone rod, or bank fasciolata. For your case, you have used the bank fasciolata is the good choice, as you can't harvest the autologous fasciolata in this 10 months young boy, as there is no development of the fascia in proper until the 4 years of age. So another material could be the silicone rod, but I'm using for many years with good result. And regarding your question about the genetic testing for blepharophimosis syndrome, the prenatal testing for pregnancy at increased risk, if possible, if FOXL2 is identified in the family member, then only. The test is not easily accessible in low or middle income resource countries. And I don't get in genetic testing done for the clinical reason, as clinical diagnosis is so obvious. So we do not do genetic testing for regular basis. Now come to the single stage versus two-stage surgery. My preference would be the single stage. I do the lateral canthoplasty, then medial canthoplasty, then frontalis sling surgery. So what are the advantages of single stage over the stage surgery? Single stage is low anxiety or emotional hits to the patient and patient party. It is a cost effective. There is no need of multiple hospitalization and recovery time is shorter, and no follow-up losses will be there. And it is proven that equally good functionally and cosmetic results with single stage surgery. In conclusion, a well-planned and meticulous surgical evaluation and accurate measurement, as mentioned above parameters, with single or stage surgical correction will give long-term satisfactory cosmesis and functional visual outcome for long way. The challenging cases in oculoplasty also adventurous. So it is not always easy to ride the mountain, but it is very satisfactory once you ride in meticulous way and reach in the top of the mountain. So your case is very challenging, but it is very interesting as well. Thank you very much. I'm so sorry I couldn't show my slides. Thank you.
Thank you, Dr. Rohit. Maybe we continue first with Dr. Weldu for the second panelist.
Thank you for the moderator's introduction, and thank you, Yunia and Dongmei, to have me here to attend this wonderful conference. And I think I must give the congratulations to Stephen Yang, Dr. Stephen Yang, and I see the case carefully, and I think it's really a challenging case. So I will answer your questions in my slides and introduce our experience in China. So I will share my slides first. And blepharophimosis ptosis epicanthus inversus syndrome in China, and we have a lot of doctors have a lot of research in this disease, especially Dr. Fai Xianqu and Dr. Li Dongmei, and they did a lot of research. And we know that the BPES is an autosomal dominant genetic disorders with a low incidence rate. And this is because of the gene of FOXL2, and we can make sure that this is the pathogenic factor now. And according to that, is if it's combined with POF, it's divided into type 1 or type 2. And in China, and Dr. Xianqun Fan gave a lot of research about the families. And Dong Mei Li did a lot of research about the factor about the combined syndrome. And the incidence rate of the disease is about 1 to 50,000 in the world, but in China it's a little higher, is 1 to 10,000, but it's not the same in every place, and it will be higher in northwest area, especially in Guizhou province. And for children with small eyelid fissure, the problem of visual function should be paid attention to. And the study of the instance of amblyopia, strabismus, and ametropine in children with BPES in China was 58.7% and 8.6% and 26%, and so on. And BPES is also combined by lacrimal gland loss and lacrimal gland hypoplasia sometimes. And this is a typical clinical manifestation, and Dr. Stefan has described before. And for the surgical intervention, there is two methods, and one of is one-stage procedure, another is two-stage. But in China, that many doctors give a lot of research about that, and they found that in one stage, although there is a lot of advantages, such as only one-time general anesthesia and less cost and less recovery time, but sometimes it's unstable because the power of horizontal and the vertical is totally different, and it will decrease the result, the final result. So there is consensus in China that most of the doctor will choose two-stage intervention. And firstly, we will do medial canceloplasty. We will use Vivis flap, mustard or Z-plasty or inverted V. And then we will do the second step of ptosis correction. And we will do the medial canceloplasty and lateral canceloplasty at the same time. We will choose the age of 3, about 3. And the blepharoptosis correction will be done after 3 months or half a year after the first surgery treatment. And we will use method to enhance the strength of the levator suspension muscle and using frontal muscle strength. And we also can use superior rectum muscle strength also. But because most of this kind of patient is severe ptosis, so so frontal muscle is most to be used. And this is our frontalis muscle flap suspension patient. And some patient can use conjunct fissure sheath suspension also, but conjunct fissure sheath is not very strong for every children. So we will try in our surgery to make sure if this if CFS is strong enough to make the suspension. And this is the 2 steps of the surgery. And firstly, we did the medial and lateral canceloplasty, and the second we will did frontalis muscle flap suspension. And the conclusion, and now we can make sure that the gene of FOXL2 is a pathogenic factor. And if there is a question from Dr. Stephen Yang that if it is negative, where we did the further checking, we will not choose to do the further checking because it's not very sure, because many factors was found, but it's not very sure. It's only the positive factors. And for the surgery intervention, so most Chinese doctors, including me, will choose the 2-stage procedure, expect very special cases. So this is the oculoplasty teams in Liaoning province of China, and welcome to our province. Thank you.
Thank you, Dr. Willie. Dr. Sunny, you have any question there?
Yes. In summary, I think both of our panelists agree that in addition to ptosis and medial epicanthoplasty, one thing to address is the lateral canthoplasty. That is one part. But I think one of the questions that Dr. Stephanie have is the residual part of a little bit of the medial epicanthic fold. She already used the technique once already over the region. Any additional tips of releasing a little bit more and unfold it a little bit more from both of our panelists? Dr. Rahid.
Yeah, thank you, Sunny. I think just leave this question to the patient party, as the picture is showing that it is very much physiological for the Mongolian Asian Asian population. If they are not bothering with this, leave it that. If they are requesting you for the correction, can be done after 6 to 9 months, little bit correct the ptosis with the frontal sling adjustment, or middle canthoplasty can be revised. Otherwise, it seems Stephanie has done fantastically good job, though he is trying the new modified method described by my friend Hosek, and I also will definitely try this one. It seems very promising result given by the picture shown by Stephanie. Thank you.
Professor Wilu, do you have additional tips on how to correct the residual medial epicanthic fold?
Because for medial epicanthus correction, so many doctors, every doctor has their own tips for that, and there is many methods, and I will use YV sometimes. Mostly will use YV because it can correct very widely and enlarge more size of the eyelid, will enlarge the size of horizontal direction. Thank you.
I also agree that we probably don't need to rush, as the facial bone will continue to grow and stretch the tissues around the issues. We even have, for a short while, have patients that after they become teenagers, we recommend them to have a bit of a rhinoplasty to further tightening the tissues before we do a just isolated lower eyelid epicanthoplasty. Thank you very much.
Can I ask Stephanie one question? When you do this modified epicanthoplasty, after the plication of the middle canthal tendon, What about the skin, excess skin you find in the superior and inferior? Do you trim
Yes,
or
yes.
you just adjust?
Yes, we definitely trim the excess skin before.
Yes,
Thank you very much.
I think it is important to remove the excess skin at the medial after Wi-Fi plastic or the other zit plastic. Okay, I think it's a good session. We will continue to the fourth.
Yeah, to the fourth presenter, Dr. Nasim Vanessa Mansurali, who is the chairperson of the Malaysians Oculoplastic Groups. And for our panelists, we have Professor Milan Naik, which is the Professor of Oculoplastic Surgeries of LV Pasar Eye Institute, as well as Dr. Phyllis Ranchi, who is the Vice President of the Philippine Society of OPRS. Shall we have Dr. Nasim?
Hi, can I share my screen?
Not yet.
Yeah, I'm sharing.
Yes, it's good.
Let me see if I can. Okay, I can't go to slideshow. Just give me a minute.
Slideshow, I think slideshow below.
In your presentation mode, there is a button.
Okay, let me see if I can start there.
Okay.
Okay. So I will today be talking on asymmetrical looking eyelids, a bane of Asian blepharoplasty. I would like to thank the Indonesian Oculoplastic Society, Dr. Yunia, and the Asia Pacific Society for giving me this opportunity to share my experience in this challenging subset of patients. So I will present a series of cases and how I managed them. 30-year-old lady who presented with history of Asian blepharoplasty, unsatisfied with asymmetrical lid crease. She had underwent revision 2 times by primary surgeon with no improvement. She presented to me keen on improving symmetry. On examination, there's mild ptosis with a deep sulcus over her right side. She underwent posterior approach white line ptosis correction with restoration of symmetry and correction of deep sulcus. Case 2 is a 25-year-old lady with his history of asymmetry after Asian blepharoplasty and multiple revision surgeries, including fat grafting. Her main concern was right upper eyelid asymmetry, scarring, and lumpiness. On examination, there was right upper eyelid scarring, puffiness, and ptosis. So due to extensive scarring and multiple surgeries at the skin incision, she underwent posterior approach ptosis surgery, followed by anterior approach removal of scarring and previously grafted fat. There was a large amount of fat under the preseptal and pretarsal plate, which was gently removed without disturbing the underlying structures. So this is her before surgery, and this is her after surgery, and there's resolution of lumpiness and improvement in the ptosis. A 50-year-old lady with history of blepharoplasty a few years ago, she presented with complaints of deep sulcus with multiple lid creases and asymmetry over her right upper eyelid. On examination, there were multiple lid creases with medial ptosis and sunken sulcus over the right upper eyelid. Patient underwent right upper eyelid posterior approach ptosis correction to improve symmetry, correction of deep sulcus, and multiple lid creases. This is her before, after surgery. Now, this patient was rather unique. She was a 60-year-old lady who had underwent blepharoplasty in a salon many years ago. She was extremely unhappy with the outcome. She felt that her sulcus was too deep, her lid crease was too high, and she was looking tired and rather aged, and the rounded appearing lid crease, which was rather unnatural. So this is her on table when I was doing the revision of the posterior approach white line levator advancement. This is the lid crease that Asians should have, about 7 millimeters, which is already on the high side. And this was where the original incision was made, which was about 10 to 11 millimeters, which is too high for Asians. So she underwent posterior approach white line levator advancement. And this is her 5 days after surgery. Actually, when she first came to me, I rather under promise her. I told her I'm not sure if I could correct all her problems in one stage. And just a simple posterior approach white line levator advancement resolved her deep sulcus, her thick lid crease, and even cured her lid asymmetry. And she was extremely happy with the outcome. This is one of my own patients who had she had bilateral ptosis, bilateral dermatochalasis, eye bags, and mid-face droop. And I did a bilateral upper eyelid blepharoplasty with ptosis correction and eye bag correction and mid-face lift. And she was presented to me with asymmetry in the lid crease. She wanted this eyelid to be brought up because she said that she couldn't see well. It was disturbing her vision. She was a high myope with rather poor vision, and she said that lifting up this lid would help her tremendously. So I redid her right eye posterior approach ptosis correction, and she was quite happy with the revision, and both the eyelids became symmetrical. So this is how the surgery is done. I'll play a quick video of the surgery. So a traction suture is placed and the eyelid is everted with the DMARS, and then local anesthetic is injected in the conjunctival region superior to the superior border of the tarsal plate. Cautery is done to create a raw wound edge for the conjunctiva to adhere back. Then incision is made in the conjunctiva and the white line is identified. 2 5/0 sutures are placed to advance the white line, pass through the superior border of the tarsal plate and out through the skin. So there's no skin incision made in all these cases that who did revision. I generally use 2 5/0 sutures and leave it there. They dissolve when they on their own about in a period of few weeks. When they're dissolving, they do give rise to some inflammation which subsides on its own and there's nothing to worry. So this is my second 5/0 suture that I'm placing from the white line to the upper border of the tarsal plate and out through the skin. Now, the only common problem that I sometimes encounter is that they can have corneal aberrations because of the slightly raw undersurface of the palpebral conjunctiva. And you need to monitor them with a slit lamp and place a bandage contact lens if they do have any corneal aberration, and it heals within a few days. So I'm checking my lid contour and height, and I'm quite happy. And I just finalize my sutures and tie the knots and cut them. So my learning points are that preoperative photographic documentation of pre-existing asymmetry is important. Asymmetrical lid crease can be accompanied by mild ptosis and at times sunken sulcus. Close clinical examination is needed to assess the patient and decide on the type of revision surgery. Posterior white line approach ptosis correction gives a good outcome in the above cases. Autologous pad injection in the pre-tarsal and pre-septal space can give rise to mechanical ptosis and unevenness of the overlying skin. So generally, I do examine my patients when they have a lot of redundant skin. It's important to lift up this redundant skin and take a video of the lid margin to show the patient that there is a pre-existing symmetry. So there are no disagreements post-operatively. And if there is an obvious pre-existing ptosis, it's best to correct it with the blepharoplasty. So my questions for the panel is, any tips and pearls on how to avoid asymmetry, mild ptosis in patients undergoing Asian blepharoplasty? In East Asian patients who need lid crease formation, do you open the orbital septum to identify the levator and place lid crease forming sutures? And give rise to some post-operative ptosis. Opinion on autologous fat transplantation in upper eyelid, any particular preference and technique? I'm extremely grateful to this paper on posterior approach white line advancement ptosis repair by Raman Malhotra. It has helped me tremendously in my journey towards posterior approach levator advancement. With that, I would like to end this session, this presentation. Thank you very much for the opportunity.
Thank you. Can we have Professor Millen?
Yeah, hi Vanessa. Can you hear me?
Hi. Yeah, I can.
Well, wonderful presentation and great results. I'm just sharing my presentation here. Can you see that?
Yes, we can see you. We can see your presentation.
Okay, that's actually your slides. And
well, let's be there. Hope to see you all here soon.
Okay, can you see the slide number 1? The case number 1?
Yes, we can.
Yeah, here I thought the result was really excellent, and I was just wondering whether instead of a white line advancement, would you have thought of a Mueller's muscle conjunctival resection in this case, because I know white line advancement has come into vogue again, but it's still very difficult for people to imagine that reverse anatomy.
Well, yeah, it could be one of the options, mullerectomy. I used to do it before I moved into wide line advancement. But in this kind of subset of patients with a hollow sulcus, and I've done it for routine ptosis, it might work in this subset of patients too, but I've not tried yet.
Well, I do agree that posterior approach would be best for this kind of a mild asymmetry. I would have personally been more comfortable doing an MMCR just because I haven't done too many white line advancements. And in that case, my question was, how do you decenter it? Because for white line advancement, this lady, you can see that medially the ptosis is slightly more than lateral. So how do you make these small changes with white line advancement? Maybe you could give us some tips.
Generally, my sutures are placed at specific places. The first one is just medial to the pupil, and then the second one is about 3 or 4 millimeters lateral to it. Actually, it's very simple, the technique, in the sense that I don't really need to readjust much. I just put my stitch at the white line and the whole levator comes forward. I don't really need to like titrate or measure. Even in patients who have asymmetrical ptosis, one eye has more and another has less, I just go at the white line bilaterally and it gives me quite symmetrical lid creases.
Okay, great. Thank you. The second case was also wonderful, and I think you've done an excellent job with the fat removal, deepening of the crease there. Medially, maybe there was a little bit more scope. So one of your questions was whether you would open up the septum and attach the crease to the levator. I prefer to do that. So probably medially here, if the dermis was attached to the levator directly, the crease would have been deep enough, just like the other eye. But these are very challenging cases. That slight little temporal flare that you see, not every patient will be bothered by it, but if it is, you can always, bring it down a little.
Yeah.
So
I did offer that option to her to bring it down a little bit.
Right.
Actually, in this case, I had underestimated the amount of fat that was there. So
Correct.
ideally, I should have taken out all the fat and then corrected the ptosis. But I corrected the ptosis first and then I took out the fat, and it kind of, maybe there could have been a slight overcorrection. So I asked her if she wanted to bring it down. And her tissue planes, I couldn't identify things clearly because there was so much of scarring because of a lot of revision surgery. So it was quite a challenging case, this lady.
Right. So here also it was a levator attachment or advancement.
It was an advancement, just the white
Right.
line. But
So
I couldn't, sorry?
Yeah, go ahead.
I couldn't identify the white line very clearly in her because there's a lot of scarring on all over the eyelid.
Yeah, that's exactly why I was thinking whether an MMCR could have been a more predictable option here, knowing that the ptosis is mild. So you address the crease as well as do a MMCR. Just another alternative. Not both ways are equally perfect here. I think your third case, this had excellent results, and I didn't have any comments, only compliments for you. And the other lady whose bleph was done in a saloon, I think I was under the impression that if you revise it, the scar initially being higher, she would not have a nice fold of skin falling in front of her tarsus, but she showed great results. And those are the kind of cases where I might think of putting fat, if at all.
Yeah, I was surprised with the result. I'd underpromised her.
Thank you so much. Wonderful cases and great learnings.
Thank you, Mil.
Thank you, Dr. Milin. Maybe the next panelist, Dr. Felis.
Good afternoon. Are my slides visible?
Yeah, they are.
Thank you. Good afternoon, everyone. So before I start, please allow me to thank APSOPRS and INA SOPRS for the kind invitation. So let me preface my answers by reiterating that eyelid asymmetry is very, very common, with an incidence of around 30 to as high as 90%, and that it is not necessarily an unaesthetic or unattractive feature. But in patients who are concerned with their uneven eyelids, there are many ways that we can address them with blepharoplasty. So the first question of Dr. Vanessa is on tips or pearls on how to avoid asymmetry. So the preoperative clinic visit is the longest clinic visit for me, where I take meticulous measurements with the patient supine and upright. So the contour of the crease is always seen in relation to the surrounding structure. So I try to measure how it is related to the midline, to the brow, to the corneal reflex, and to the palpebral fissure. I usually do a 5-point fixation for the lid crease. So pre-op, I note the medial end, the lateral end, and the center of the crease, and 2 additional bisecting points. And I measure the distance of these points to the base of the brow, the upper lid margin, and to the canthi. I also take note of the palpebral fissure height at 3 points at the center and at the nasal and lateral limbus. In patients without a lid crease, we try to simulate the post-operative options with butterfly sutures or monolid tape. And this way, the patient and I can agree on what kind of lid crease contour she prefers. And lastly, I try to address any issues in the surrounding structures prior to surgery. So for instance, this patient had asymmetric frontalis contraction, which resulted in her left brow lifting more when talking. So we put some botulinum toxin to the frontalis 2 weeks prior to surgery. And afterwards, we proceeded with her blepharoplasty. She wanted downward sloping crease and decrease in her puffiness. And the picture on the right is the patient satisfied 1 week after surgery. Intraoperatively, these are some of the things I do for all my patients undergoing blepharoplasty. The first is using a low volume and concentration of the infiltrated anesthetic, usually 1% lidocaine with 1 to 100,000 or 1 to 200,000 dilution of epinephrine. Using the minimal anesthetic gives me less tissue distortion intra-op and also results in less akinesia of the eyelid retractors and protractor. So I usually excise a skin muscle flap and follow this with grid or whole surface bipolar coagulation over the septum to shrink the underlying fat. And this will also address any focal mild drooping of the upper lid margin. I also ask the patient to sit upright so that we can check the lid contour, the eversion of the lashes, and the symmetry of the scleral triangles before closing. So this patient had no lid crease on her left upper eyelid. This is an intra-op photo of her sitting upright with 2 temporary crease sutures at the nasal and lateral limbus. So I usually take photos intra-op and show it to the patient before I do the final closure of the skin. And usually I don't dissect the pretarsal orbicularis from the tarsus, but in selected patients with puffy lid margins or those who want a large tarsal platform, usually for their makeup like this patient on top, I separate the pretarsal orbicularis from the tarsus, lift it upward, and then I debulk the redundant muscle at the lower lip of the incision. And for patients with fibrosis from previous surgeries, such as in the cases presented by Dr. Vanessa, I try to remove as much scar tissue, both internally and externally. And so for this reason, I almost always prefer approaching the lid from the skin rather than from the conjunctiva. So the second question is, in East Asian patients, do we open the orbital septum to put the lid crease forming suture? So in general, I don't do this. In general, I try to avoid opening the septum as much as possible. Instead, I close the lid incision with a running non-absorbable monofilament suture, usually a nylon 6-0. The first bite is at the inferior lip, and the second bite is a shallow bite just above the superior edge of the tarsus. And the final bite is in the superior lip of the incision. And the last question is my opinion on autologous fat transplant in the upper eyelid. So I have very limited experience for this procedure because it's something I just prefer not to do. I feel that the results are very unpredictable. So the fat, as we know, can shrink and expand. And it results in closer follow-up for a longer period of time for patients. So I find that patients are satisfied for just a short period of time, and then the fat will change, and then they'll come back for a follow-up visit, which personally, I just prefer simpler procedures with predictable outcomes. So if patients come with sulcus deformity or volume problems, I can do a conservative redistribution of the upper lid fat pads, but I inform the patients that my preferred solution is just hyaluronic acid filler, or botulinum toxin to the frontalis to flatten the brow. This is my last slide. Thank you very much, Dr. Mansurali. Congratulations on the good surgical outcomes. I hope I was able to answer your questions, and thank you to everyone for your attention.
Thank you, Felice.
Thank you very much for Dr. Nassim, Dr. Milenaik, and Dr. Felice. I'm sorry because the admin remind me that the time is almost up. So maybe we can continue to the next speaker. Please, Dr. Sani.
Yeah, our next presenter is Dr. Javid Santiago, and we have, she's the head of St. Luke Medical Centers in Philippines. And for panelists, we have Dr. Kashima, who's the director of the Oculofacial Clinic in Tokyo, as well as Professor Kun-In Wu, which is our president-elect for APSOPRS and professor of oculoplastic in Samsung Medical Center. Shall we have Dr. Santiago?
Hi, good afternoon. Can you please play my presentation? Thank you. Hello, everyone. I'm Dr. Yvette Santiago Gatmaitan, and I would like to thank Dr. Yunya Irawati and the organizers of this joint webinar for this invitation to share my case. I have no financial relationships to disclose. My patient is a 52-year-old man who suffered from a complete third nerve palsy of the left eye, secondary to previously undiagnosed uncontrolled hypertension. He had complete ptosis with zero levator function, and his left eye was deviated down and out. Incidentally, he also had ipsilateral optic neuropathy from the same cause, so it was a non-seeing eye. He therefore did not suffer from binocular diplopia. The rest of the cranial nerves were intact. He came to me for cosmetic reconstruction of the eyelid 8 months after the onset of ptosis. I proceeded to do an uneventful frontalis sling suspension surgery using a 0.78 millimeter diameter silicone sling with attached needles, like in this photo. I don't have an actual photos or a video of the patient's surgery because this was supposed to be a routine procedure, so I will just explain my technique using an online photo. I used the Fox Pentagon technique as shown here. I made 3 incisions above the brow, 1 central incision 10 millimeters above the brow and centered over the pupil. Blunt dissection was done superiorly to create a pocket for the to insert the sleeve of the sling later. Medial and lateral incisions were also made halfway between the limbus and canthus on each side, just on top of the brow. The needle was then inserted 3 millimeters above the lid margin horizontally, and the implant was coursed under the suborbicularis plane through the previously made incisions to create this pentagon. The post-operative course was likewise uneventful, except for some lagophthalmos that resolved after 1 week. The patient was happy with the outcome until 2 months later, when he reported that he felt something snap and then there was again complete ptosis. He denied any trauma, swelling, or pain. I checked the implant by opening the central incision and retrieving the implant to attempt to tighten it, but there was minimal resistance when I was pulling it. The eyelid did not move. Instead, I inadvertently pulled out a broken sling. I placed it over on top of the skin to try to trace how much of the implant I had retrieved, and it appears to have snapped just below the medial and lateral incisions. I ended up just closing the central incision again and planning for the next step later. The main challenge here was explaining to the patient what had happened and why we were back to square one. I have implanted many silicone slings in the past and used this particular brand without any issues. So I could not explain why it happened. I had my theories. It could have been my fault. Maybe I accidentally nicked the silicone tube while I was inserting the needle. Although this has never happened before because I take extra care not to puncture the implant with the needle by carefully retracting it away from the pointed tips during insertion. My other theory is it could have been the implant's fault. Maybe it was subpar in quality. I planned to send it back to the manufacturer, but then the pandemic happened. Anyway, it was difficult to convince the patient to spend for another sling, so I decided to do a frontalis muscle flap advancement. This technique involves creating a muscle flap by disinserting a part of the frontalis muscle from the orbicularis oculi, coursing it through a tunnel in the pre-aponeurotic plane, and attaching it to tarsus directly. So tarsus was exposed through a lid crease incision. Lid height and contour was adjusted so that it will be symmetrical to the right eye. This yielded acceptable results for the patient. He was happy. I did notice a 2 millimeter decrease in palpebral fissure height a month after surgery, but it has remained stable for the past 18 months. I also could have added a supratarsal stitch here medially just to improve on the appearance of the lid crease. Anyway, the patient was happy with the results. So my questions for the panel of experts are the following. Do you have any pearls or tips on insertion of silicone sling with attached needles? Any theories on how the sling could have broken? And lastly, what is your experience with frontalis muscle flap advancement? Again, thank you for allowing me to share my case. I look forward to the discussion.
Thank you, Dr. Yvette. I will continue with the first panelist, Dr. Tomoyuki. Please, Dr. Tomoyuki.
Good afternoon, ladies and gentlemen. Thanks, Prof. Yunia and organizing committee to invite me to the session. I am going to comment of this case presentation. I have no financial disclosure. The case is 52 years old male. He has left severe ptosis. His visual acuity may be damaged from optic neuropathy.
Kau hilang suaranya.
Sorry, I have to talk. The symptom of Sardinal palsy is
Sardinal palsy patients have diplopia. Therefore, they usually do not attempt to elevate eyebrow and eyelid. Because his left eye had optic neuropathy, he may not feel diplopia. Then, let's go back to the case. He don't have eyebrow elevation. The patient don't attempt to open the ptotic eye due to diplopia, and frontalis suspension don't work for the patient of no eyebrow elevation. But he's still eager to repair ptotic eye. You must think about eye movement and Bell's phenomenon. Bell's phenomenon is a medical sign that allows observers to notice an upward and outward movement of the eye when an attempt is made to close the eyes. This patient may not have enough Bell's phenomenon. I cannot catch the condition from this photography, but he may have slight lagophthalmos. Corneal erosion may occur after ptosis surgery. Ptosis surgery sometimes damages corneal surface of elders, especially the patient of ptosis without Bell's phenomenon. Should observe the symptom of corneal erosion and diplopia carefully. In 2020, we performed 4,016 oculoplastic surgeries. We accept international fellows. Welcome to visit us. Thank you for kind attention.
Thank you.
Thank you. And the second panelist, Dr. Kyung In-wo, please.
Thank you, Dr. Yvette Santiago Gatmaitan, for sharing your excellent case with us. My name is Kyung-in-woo from Samsung Medical Center, Seoul, Korea. As Dr. Gatmaitan pointed out, this is very rare to have a case of early failure of frontalis sling. Causes of early failure of silicon frontalis sling can be speculated as follows. First, sling slippage can result in this complication, though this is not relevant to this presented case. For this condition, anchoring of the sling material to the tarsus after a skin incision is needed. Second, breakage of sling material can result in this complication. Defective product and surgical manipulation can be the cause. There is interesting research on tensile strength of silicon rod. The authors measured tensile strength of the silicon rod after doing 3 different manipulations. This photo shows the microscopic examination of silicon rod manipulated with hand tie, smooth forceps, and toothed forceps. You can see damaged surface in the toothed forceps group. This study revealed that manipulation with toothed forceps led to statistically significant decrease in the overall strength of the silicon sling. We can learn lessons from this case. Inspect the sling material before use. Avoid silicon rod manipulation with toothed forceps. Extra caution is needed when the needle is reinserted through the snip incision site. And apply proper tie strength to prevent cheese wiring effect of the suture material. Let's move on to frontalis muscle flap suspension. From a review article in OPRS published in 2018, we can learn present practice level of frontalis muscle flap suspension. The authors said that most studies were originated from Asian countries, especially China, Taiwan, and Korea. The frontalis orbicularis muscle advancement has been judged positively in all reports analyzed. However, the level of standardization of the surgery is low, and the reported series are not homogeneous. Furthermore, there was no comparative study done. This procedure has an advantage of not using sling material, and there is possible advantage for a patient with poor protective mechanism providing dynamic function of frontalis muscle. However, steep learning curve for surgical skill can be an issue, and lack of standardization of the surgery is also a limitation. I'd like to share a case of severe exposure keratitis needing releasing surgery after frontalis muscle flap suspension. This case was kindly provided by Dr. Hwa Lee from Korea. This is a 71-year-old man with CPEO. Emergency contact was done from a plastic surgeon who performed frontalis muscle flap surgery for the patient. The patient complained decreased vision and severe ocular pain after the surgery. He showed severe exposure keratitis. The corneal status got worsened in spite of lubrication and suture tarsography. The keratitis did not improve until he underwent a flap releasing surgery. We can learn lessons from this case. Great caution is needed for patients with defective corneal protective mechanism. Undercorrection to just open the visual axis should be planned. If exposure keratopathy occurs in spite of lubrication therapy, prompt measures with raising and tightening of the lower eyelid as soon as possible, and release of sling or frontalis muscle may be warranted. Thank you for your kind attention.
Thank you for all the speakers. I think because of time constraint, we will continue to the next speaker. Please, Dr. Sani. Thank you so much.
Our next presenter is Dr. Riani Ana, and she's from Indonesia. And our panelist is Dr. Stacy Lam from the Chinese University of Hong Kong, as well as Dr. Tami Hantona Osaki, Professor and Chief of Plastic Departments from the Federal University of Sao Paulo, Brazil. Shall we have Dr. Riani?
Good morning, doctor. I thank you to moderator. All finalists today, I would like to present a case with the title of surgically treated traumatic ptosis. I have no financial disclosure or conflict of interest with the presented material in this presentation. Male, 61 years old, to come to our hospital to show the upper eyelid dropping in his right eyes with history of trauma. He was being stabbed by wound from the lateral side. After being stabbed, he no longer can see and struggle in open his eyes. After 6 months, there's no improvement. Patient was referred from hospital in South Sumatra for management for the eyelid. This patient did not complain about the red eyes, eye discharge, or ocular pain. There is no complaint for the left eye. From the clinical examination, we found of the patient has a scar, one-third medial of to superior of eyelid, and MRD1 to minus 2 millimeter, and MRD2 6 millimeter. Height of palpebra to fissure of 4 millimeter. Margin limbal distance was 3 millimeter. Levator function was 9 millimeter. Bell phenomenon was positive. We do 2 aspect tests to distinguish the possibility of the myasthenia gravis. There is no any pathology finding an anterior segment. For segment Foster, we found that pupil looks pale, and there is increasing in cap over D ratio in 0.9, decreasing arteriovenar ratio about 1/1, pale color. The macula, we still has fovea reflex, and for the retina, we found there is pale vascular contour. Based on history and clinical finding, we concluded this patient is moderate ptosis, traumatic of the right eye with optic nerve atrophy of the right eyes. And we're planning to do a transcutaneous levatorexation of the right eyes. This is a summary for the surgery. First time we do the skin mark at a 6 millimeter above of the eyelid crease. We draw a skin marking at the lid crease and inject the lidocaine for local anesthesia. We using a 15 blade surgical blade used to make an incision through the skin and orbicularis muscle along the eyelid crease. We did both blunt and sharp undermine until we found the tarsus. In this case, we use the small blepharoplasty is also performed. The thermal cauter is used to access the skin of the superior of the palpebra. We did ballooning of the tarsus to separate of the molar muscle and conjunctiva. We did to measure the aponeurosis as many as 50 millimeter and suture aponeurosis at central, medial, and lateral side. We asked to the patient to open the both eyes to inspect the latmetically of the light and contour with the level should be the same or either higher than then it's below. We did resect the levator for 15 millimeter. We closed the skin and reform the crease with 6.0 absorbable suture with paste through the edge to the lower skin flap and into the levator resection, levator muscle, and out through the edge of the upper skin flap. This is a follow-up day 1. We found that there is still edema and upper eyelid, so MRD1, MRD2, fissura height, palpebra, and margin limbal distance, and levator function cannot be assessed. The suture was good. There is no any blood and pus. The patient was discharged and scheduled to come to outpatient clinic 2 weeks after. This is the follow-up of 14 days. We found the edema was subside, then there was a scar as long 50 millimeter lies from medial to the temporal of the upper eyelids. The MRD1 is measured was 2 millimeter, MRD2 was 6 millimeter, and fissura of palpebra height was 8 millimeter. Margin limbal distance was 8 millimeter. After surgery, better than surgery before was 3 millimeter. Case analysis: a man 61 years old since 6 months ago suffered from difficulty opening his right eye. This patient first reported the complaint after being stabbed by wound from the lateral side. Then the doctor left the wound and sutured the palpebra 4 days. We diagnosed the patient to traumatic ptosis. We do to found the levator function was 9 millimeter and Bepanamine was positive, and we plan to do the levator excision. How long should we resect? We're using Albuterol MRD formula from this patient. Only one eyelid is involved, and we plan to do match the pathotic eyelid height to a normal lid. So the amount, the resection found of MLD normal lid from this patient was 8 millimeter minus MLD pathotic lid was 5 millimeter multiplied by 3, so we get resection as long as 50 millimeter. The method was confirmed Bird method for the amount ptosis as 2 millimeter and levator function was 9 millimeter. The weight guesstimation resection was levator excision 15 until 21 millimeter. For this patient, I want to interview by the complication might happen, what is over and under correction, and what to do with what it happened. And there's another possible approach to treat this patient. So in this opportunity, I would like to ask some questions to the panelists. What factor must be considered to avoid under and over correction? What to do? There is over or under correction. Is there another possible approach to treat this patient?
Thank you, Dr. Riani. I continue with the panelist, Dr. Stacy Lam from Hong Kong. Would you please proceed with your comment?
Hello, can everybody hear me?
Yes.
Okay, great. Thanks, Dr. Junior, for the invitation, and I would like to congratulate the presenter, Dr. Erna, for handling the challenging case beautifully. I am Dr. Stacy Lam from Hong Kong. To answer your question, we can go back to your slides for the pre-op photos. So going back to the basics of what is traumatic ptosis. It is defined as anything with a decrease in lid height after trauma. So what is the underlying cause for your case? So generally, the cause for traumatic ptosis can be due to direct injury to the levator muscle, to the Mueller's muscle, such as in direct lacerations, can be due to injury to the aponeurosis with dehiscence of the aponeurosis from the tarsal insertion. This is usually due to extensive stretching or pulling, such as in a fishhook injury. Thirdly, it can be due to mechanical ptosis if there is extensive cicatricial changes in the skin. Fourthly, traumatic neurogenic ptosis if it's third nerve or any injury to the sympathetic fibers from the intracranial, superior orbital fissure, or anywhere along the orbital course, such as in the fracture of the orbital apex. And finally, can be mixed ptosis. And also, we cannot forget any pre-existing ptosis before the injury. So going back to your pre-op photo, I think that your underlying cause could likely be mixed. The skin scar indicates that there is possibly a direct laceration to the levator muscle and the Mueller's muscle. There could also be a neurogenic component, as the patient is a non-seeing eye. It could be due to optic nerve injury with the third nerve. Even though you didn't mention the extraocular movement, I note that there is divergent squint in the photo. I'm not sure if this is due to the third nerve or if it is due to the poor vision with divergent squint. The patient has excess skin on your pre-op photo, so I don't think that cicatricial cause is a likely reason for the traumatic ptosis. So back to your question, what do we have to consider to avoid under or over correction? So intraoperative adjustment is most important. Since myogenic ptosis is the most likely cause in your case, we have to remind ourselves that myogenic ptosis actually has the highest likelihood of requiring multiple surgeries compared to other causes. In the surgery, if you suture the remaining levator and you realize that there is overcorrection, we can consider a handbag suture or a spacer graft. If the suture you do is undercorrected, we can consider repairing the levator and resecting the levator resection and a frontalis suspension. Since this is a traumatic ptosis, the distal part of the levator may not be viable anymore and unable to contract. So resection will be needed. Even if you repair the levator muscle directly, there will still be residual ptosis. And for your last question on what other approaches we can consider, if there is some Mueller muscle involvement, I would consider Muellerectomy. And if there is very poor levator function, regardless of the cause, I would consider doing a frontalis sling. And another issue that we have to keep in mind is, when should we do the surgery? For your case, it was managed 6 months after the initial surgery. And for muscle surgery, it is best if it is done immediately. Of course, if there is delayed repair, we can still directly repair the levator. And as I said, there may require to have levator resection and frontalis suspension. For aponeurotic or neurogenic causes, some of these patients can have spontaneous recovery. And if there is extensive scarring, I would also wait for 6 months to allow for the scar tissue to stabilize. Again, congratulations, Dr. Erna, on the wonderful surgical outcome. I hope I have answered your questions.
Thank you, Dr. Stacy. And then we continue with next panelist, Dr. Tami Hentona from Japan. Would you please?
Good morning, everyone. I would like to thank Dr. Yunya Irawati and Dr. Dongmei Lee for the kind invitation. It's an honor to participate in discussing Dr. Erna's case. Traumatic ptosis are usually challenging cases. It's usually recommended to wait approximately 6 months after trauma to indicate surgery, as was performed in this case. Dr. Erna raised some questions regarding the case. So first question was if there would be another possible approach to treat this patient. Anterior levator exploration would also have been my technique of choice. I think the anterior approach is more adequate for this case. I would not address it with a conjunctival Muellerectomy because the ptosis was severe and the ptosis was secondary to an eyelid trauma. In these cases, I feel more comfortable assessing the ptosis via an anterior approach to be able to better explore the levator aponeurosis and possible areas of fibrosis secondary to the trauma. I think the case was well conducted. I only had the impression that the incision medially was a little lower. The second question was how to avoid under or overcorrection. So undercorrection is usually more frequent than overcorrection. It's usually recommended to overcorrect 1 millimeter due to the epinephrine effect. In order to avoid under or overcorrection, I recommend performing the surgery under mild sedation. Then you can ask the patient to cooperate in order to assess the eyelid height intraoperatively. I also recommend sitting up the patient during surgery, during intraoperative assessment if needed, and to control hemostasis. And what to do if under or overcorrection occurs? Well, if undercorrection occurs, I would wait approximately 2 to 3 months to see if with edema reduction, a reoperation would still be needed. If still significantly undercorrected, revision with placement of advancement sutures will be needed. If overcorrection occurs, I would initially recommend downward eyelid massage and managing corneal exposure with intense lubrication. I would consider revision after 4 weeks of no improvement. So these are my contacts. Once again, thank you very much for the invitation.
Thank you. I think because also time constraint, we will continue to the last speakers. Please, Dr.
Our last speaker, Dr. Tri Rejeki from Indonesia, from Jakarta Eye Center. And our panelist is Dr. Saeed Mabu from Bangladesh, Senior Consultant from Bangladesh Eye Hospital and Institute, and Professor Helen Liu from CHA University, South Korea.
Good evening. Thank you very much. I'd like to thank for the APSOPRS and team for the invitation. My title for case presentation today is my experience in upper lid blepharoplasty as a beginner. Our patient was a 32 years old female. She had a single eyelid and wished to have double eyelid surgery. On clinical examination, there was single eyelid crease 1 millimeter with puffy eyelid both eyes, no trichiasis, and other examination of the eye was within normal limit. So we diagnosed it as a single eyelid crease with puffy eyelid and planned to do aesthetic blepharoplasty with 6.5 millimeter crease for natural look. This is the video. Central lid crease is measured for 6.5 mm centrally both eyes. Marking is then continue along the crease for both eyelids. Skin is pinched and marked laterally and medially, and the marking is united superiorly. After local anesthesia here was given, we made the incision along the lower marking, and then the upper incision was made, and skin was removed with the scissor. The orbicularis then was opened across the entire incision. Next, we cut open the orbital septum to identify the fat pad. We can see here the aponeurotic fat pad was visualized. And the central one, we removed the fat pad and we did the hemostasis. The redundant tarsal orbicularis also noted. We trim it to leave a 1 millimeter pre-tarsal platform. The eyelid crease was made by promoting 6-0 proline suture passed from the skin tarsus and the skin was closed in another suture with 6-0 proline. And from the left side here, we made the incision along the marking and skin removal with the scissor. The orbicularis also open across the entire incision. We cut open the orbital septum to identify the fat pad. We can see the aponeurotic fat pad. We remove the fat pad and then the redundant tarsal orbicularis also trimmed. Here we can see the redundant. And then the eyelid crease suture passed from the skin tarsus and the skin, central, medial, and lateral, and the skin closed in interrupted suture with 6-0 proline. On follow-up day 4, we saw asymmetrical crease for right eye 5 mm and for the left eye 6.5 mm with asymmetrical lateral length of the crease. She still complained about puffy eyelid and was unhappy. So we plan to do blepharoplasty revision. First, the height of the right upper eyelid crease was measured and noted to be lower than the left one. The desired crease height was then marked on the left upper eyelid at the same level as previously measured at the right upper lid. Local anesthesia, and we measured subbrow into upper eyelid marking both eyes. Careful incision is made with 15 blades within the marking. Skin and orbicus muscle flap is removed with sharp dissection. Dissection performed inferiorly and superiorly at the pretarsal plane. Dissection, we can see we identified the layer, the orbicularis, and then the preaponeurotic fat pad and levator aponeurosis. We removed the redundant fat pad and also in the septal orbicularis, we did the hemostasis here. You can see a lot of redundant. Crease fixation was placed by suture skin tarsus skin as shown with 6-O-proline tied off close to the knot and skin closure performed interrupted suture with 6-O-proline. For the right eye, we did removal of the knot, incision at the crease line. We also do the superior dissection, open the orbital septum. We can see in the preaponeurotic fat pad, the underlying levator aponeurosis identified. There's a lot of removal of it. We did the removal of redundant fat pad and then the strip of pretarsal orbicularis also trimmed, removal of thick septal orbicularis, and we did the hemostasis. Crease fixation was placed by suture skin tarsus skin as shown with 6-O-proline tied off, and the skin closure performed interrupted suture with 6-O-proline. This is post-operative picture. On follow-up day 7, we had 5 mm crease, symmetrical, slightly swelling, but I'm sorry we didn't have the picture and the patient quite satisfied. So the problem within this case was asymmetrical eyelid crease and unresolved puffy eyelid in aesthetic blepharoplasty. Based on the problem, we asked for suggestion from the panelists about how to reduce possibility of asymmetrical lid crease for double lid surgery and how to measure the right amount of fat excision or orbicularis muscle in superior blepharoplasty. Thank you.
Thank you, Dr. Dayan. Proceed to Dr. Said Mahbub for panelists. The first panelist, please.
Thank you, Dr. Dagmeli and Dr. Yuniaroti and all the members of the organizing committee for inviting me here. Thanks, Dr. T. Rijiki Ardiana, for wonderful presentation on her experience in upper lid blepharoplasty as a beginner. There are subtle structural differences between the East Asian eyelid and other ethnic groups. In East Asia, low tarsal height, that is 6.5 mm to 7.5 mm. Fullness of the upper lid due to brow fat extends inferiorly and becomes continuous with the upper eyelid due to perioperative fat, the greater perioperative fat distribution and lower positioning of perioperative fat may be the culprit and disrupting the upper lid crease formation. Levator aponeurosis and orbital septal fuse lower onto the anterotarsal surface in the East Asian eyelid. The eyelid looks like a monoeyelid due to lack of supratarsal crease. The most common oculofacial aesthetic surgery is double eyelid surgery. In 2016, in Korea, South Korea, double eyelid surgery was the most performed aesthetic surgery. But in our perspective, the most common indications for upper lid blepharoplasty include blepharochalasis, dermatochalasis with bilateral prolapsed lacrimal glands, dermatochalasis with aponeurotic ptosis. Before going to surgery, the importance of first listening and understanding the patient's expectations in all types of aesthetic surgery. Careful placement of skin markings and precise incision are critical steps in maintaining proper lid crease position. Care must be taken to ensure that 20 mm of skin remains between the upper eyelid margin and lower border of the eyebrow to avoid anterolamellar deficiency. It is also important to identify and expose the medial fat pad and central fat pad, and care is taken to avoid the damage lacrimal gland laterally. Excessive fat excision may cause hollowing of the eyelid sulcus, and excessive skin excision leads to postoperative lag of thalamus. Now come to question: how to reduce possibility of asymmetrical lid crease for double eyelid surgery. Asymmetry may be one of the most common complaints after upper eyelid blepharoplasty surgery. The adage is measure twice, cut once should be followed in all types of aesthetic surgery. Prior to blepharoplasty, the surgeon should be familiar with normal eyelid position and contour in addition to pertinent anatomical landmarks. Careful surgical planning and techniques are the best prevention for asymmetric lid crease. Careful placement of the lid crease markings and precise incision are an important step of blepharoplasty to get more symmetrical lid crease. If lid crease asymmetry is noted perioperatively, the lower crease can quite easily be elevated to match the contralateral lid by performing a supratarsal fixation. If significant asymmetry persists after blepharoplasty, a similar procedure can be performed to elevate the lower of the two eyelid creases. This is meant only to reform a new lid crease, not to remove more skin and orbicularis. According to Bosniak and Castellano-Jilka, if there is a redundant skin, it is easier to lower an eyelid than to elevate it because there is an adequate amount of residual upper lid skin. Second question: how to measure the right amount of fat excision or orbicularis muscle in superior blepharoplasty? The skin and orbicularis muscle are removed between the incision as a single flap generally. The orbicularis oculi is typically preserved to minimize problems with eyelid closure postoperatively. A trimming of a thin 1 to 2 mm cuff of orbicularis oculi muscle along the incision will facilitate a more natural flattening contour of the newly formed upper eyelid crease. The fat pads are addressed if prominent on the perioperative evaluation. Using a standardized scale, the volume grade of the nasal and central fat pads is graded from 0 to 3. With aging, the central fat pad volume appeared to diminish with relative sparing of the nasal fat pad. So there is a positive correlation of the volume grade of the nasal fat pad with age and negative correlation of the central fat pad with age. In general, limited fat removal should be performed in order to avoid the appearance of a hollow superior sulcus. The amount of nasal fat pad to be removed can be estimated by applying slight pressure on the globe to assess the degree of nasal fat collapse. After fat sculpting, careful hemostasis should be achieved. Nowadays, the trend in upper eyelid blepharoplasty has shifted to preservation, repositioning, or filling of the upper eyelid fat, rather than aggressive removal of the fat. The retroorbicularis oculi fat is deposited back for restoring the eyebrow volume along with its internal fixation at desired position. Thank you all.
Thank you, Dr. Syed. We proceed with Dr. Helen Du, please, the second panelist.
Hear me? Hello, can you hear me?
Yes,
Yes,
Dr.
yes.
Yeah, good afternoon. I'm glad to join the third webinar of Indonesian Society meeting with APSOPRS. Thank you, Nia, for invitation and organization of this wonderful meeting. My talk is about the answers to Dr. Hediana's questions. She did an excellent job on double eyelid surgery for correction of asymmetric lid creases. To summarize the questions, first thing is the way how to reduce possibilities of asymmetrical lid creases. The second thing is about the right amount of the fat and orbicularis muscle excision. The goal of upper bleph is to accentuate the eye appearance through creating lid creases. However, many unfavorable results could occur following upper bleph. Regarding the creases, low or high creases, asymmetry, disappearance, and multiple folds, and puffiness, pre-existing or secondary ptosis. Among them, asymmetry of lid creases is very troublesome. To reduce the possibilities of asymmetric lid creases, the best way is prevention at each step of the surgery. Preoperatively, the asymmetric preconditions should be noted, such as degree of skin redundancy, size of fissure, extent of epicanthus, brow height, and lid thickness, as well as the design. Intraoperatively, hematoma and poor surgical technique can affect the symmetry of the creases. Postoperative factors are also considered. First up, the forehead and brow examination is essential. Not only bony asymmetry, the height and the shape of the brow should be considered. And also we need to identify the lateral fullness due to brow fat or prolapsed lacrimal gland, which is common in Asian puppy eyelids. Regarding eyelid examination, as for lid skin, thickness, epicanthal folds, and preorbital fat should be checked. For the pre-existing lid creases, margin crease distance, MCD, should be checked at closer and open. Tarsal platform show, TPS, are to be measured. We also have to evaluate IPF, MRD1, levator function, and downgaze lid lag to rule out hidden ptosis or retraction. For example, this lady presented facial asymmetry and mild ptosis on the left side with secondary brow compensation. The lid symmetry was achieved by double lid surgery combined with epicanthaloplasty and levator advancement on the left side. So when we revisit the initial photograph, we could see the prominent brow fat as well as pretarsal and septal fat, and also mild ptosis on the left side with secondary brow elevation and epicanthus. Therefore, we could predict the high TPS on the left side unless we address the ptosis or design the crease line lower on the left side. After first operation, the eyebrow and lid crease were higher on the left side and the fullness on both sides. At the revision, the skin at the lower incision margin was excised to lower the crease on the left side, and more orbital fat and pretarsal muscle were also resected to address the puffiness. There is no absolute answer for the amount of removal of fat and orbicularis, but enough amount of pretarsal, septal, orbital, and brow fat needs to be resected to create the natural crease. Let me highlight the critical steps during the surgery. After design in sitting positions, regarding the skin and muscle excision, additional pretarsal orbicularis oculi muscle can avoid unresolved puffiness, and enough resection of pretarsal, preseptal, and orbital fat and brow fat is also required. Lid crease forming sutures, permanently or temporary, the height of fixation suture should be symmetric for symmetric TPS. This is a case with puffy eyelids treated by upper bleph combined with lacrimal gland fixation, and another case of upper bleph with brow fat resection in order to improve the lateral puffiness. In summary, upper bleph is a crease formation surgery resulting in fixation of levator ponderosis or tarsus to the pretarsal or septal portion of the lid. However, the best way is to avoid unfavorable result is to identify potential problem situations, including pre-op asymmetry, ptosis, thick skin, and presence of epicanthal fold. The excessive orbicularis oculi with dense fibrous tissue and periorbital fat underlying the skin fold should be addressed thoroughly. Terima kasih, and thank you for your attention.
You still mute Dr. Darmayanti and Dr. Sani.
Yes, thank you very much for all the speakers. We are very happy to see young oculoplastic really a good job here. And then I also appreciate all the panelists. You give us many insight to solve our problem to manage our patients. Thank you so much. Maybe Dr. Sani, please speak something.
Yeah, thank you very much for these wonderful sessions. We learned a lot from both the presenter as well as the panelists. Now we will pass the mic back to Professor Lee Dong-Mei as well as Dr. Yuan.
Noh 3D eye prosthetic is the first fully commercial 3D printed eye prosthetic in the world. Noh 3D eye prosthetic already implemented the prosthetic to more than 150 patients since 2019, combining the 3D technology such as 3D scan, 3D print, 3D design, and with human craftsmanship to bring us a fully customized eye prosthetic. The production process is relatively faster than the manual process. The fastest production record for a Noh 3D eye prosthetic is 6 hours. We are only using a world-class biocompatible, inert, and certified material together with experienced professional team from ocularists and 3D engineer with supervised from ophthalmologist doctors. The process of making 3D eye prosthetic is patented since 2019. With digital iris, the eye prosthetic is more realistic and natural, combined with the depth of pupil feature that cannot be found in the manual process prosthetic. For collaboration, please do not hesitate to contact us.
Good evening, everyone. On behalf of APSOPRS and INASOPS, I would like to deliver my deepest gratitude for all of you who participate in the third webinar APSOPRS and INASOPS 2021, which has been held in the past 2 days. It has been an honor to be able to share our knowledge and experience one another, particularly about the socket reconstruction and congenital anomaly in the first day and the aesthetic eyelid surgery and rejuvenation on the second day. This event was a great success. Talk. It's every one of you of the most of 900 participants from all over the countries. They are joined with us not only via Zoom and our webinar, but also in our YouTube streaming in APSOPRS and INASOPS. And once again, I would like to say thank you for APSOPRS and INASOPS team and our president, APSOPRS of Dr. Dong-Mei Lee, and our founding president, Dr. Reynaldo Diafate, our guest speaker, Dr. Peter Dolman, Bobby Korn, Don Kikawa, and Dr. Naresh Joshi, and all, of course, our lovely speaker members from the APSOPRS. And at last but not least, our sponsor from the Noh 3D Eye Prosthetic Indonesia. We hope everyone had a great learning and bonding experience and both home valuable lesson and forgettable valuable friendship. Thank you and wishing everyone a wonderful reminding of the years and see you all soon after this pandemic is gone. Thank you very much. Dr. Dong-Mei, please, if you want to say something.
Yeah, dear old friends, I just want to say many thanks to all of our panelists and speakers. And I believe during these 2 days, all of you have found the novel idea, and I really want to say appreciate the Dr. Union and her team, the hard work and the great effort to make this the webinar, the success and the wonderful webinar. We all learn a lot from this 2 days webinar. Thank you so much, and hope after COVID we can meet in person in Beijing, and welcome everyone to Beijing, but I'm not sure we can meet or not in person. So thank you very much.
Thank you, Dr. Domi. Thank you all the speakers. Thank you everyone. Thank you all the participants.
Thank you, Dr. Domi.
Okay, let's take picture.
Okay, the last picture we can take for all.
Sorry.
Yeah.
Bye. See you soon.
Bye.
Happy New Year and Christmas for all of you.
Yeah. Happy New Year and Merry Christmas. Goodbye. Take care.
Bye. Take care.
Bye.
Bye.
Harif ya.
stopped.